can start.
वेलकम स्लाइड दिख रहा है ना सब?
Yes.
Yeah.
हाँ.
Recording in
start now.
progress.
Vipinji, we are live.
Yes, we can start now.
Okay, we are live, or you will give us a signal?
No, we are live. We are live.
Okay, okay. Very good evening to all of you. Myself, Dr. Ameya Joshi. I am endocrinologist practicing in Bhaktivedanta Hospital and Research Institute and Borivali, Mumbai. I am secretary of Maharashtra Endocrine Society. At the outset, I extend my gratitude to team IMA Mira Bhayender for helping us organizing this webinar on World Osteoporosis Day. I also thank all the orthopedic colleagues for agreeing and joining and actively participating, and also Dr. Reddy for sponsoring this specific scientific program, and also Team DigiShield for the technical support. We all know or try to identify the major problems that we are facing, and maybe a couple of decades ago we identified something in diabetes which was common, and today it has become a monster. If you look at what problems could become a monster in times to come, we look at an aging population, a population that is rapidly having more number of people who are aging and above 65 years. And the major cause of morbidity and mortality in them is a fracture which is preceded by osteoporosis. Like you prevent a heart problem by treating diabetes, obesity, and cholesterol. You prevent a fracture by treating osteoporosis. Today, 20th October, happens to be World Osteoporosis Day, and Maharashtra Endocrine Society, in association with IMA Mira Bhayender, is privileged to organize this webinar, Strong Bones for Healthy Aging. We have a reputed faculty on board, and also Maharashtra Medical Council has granted us a credit point. We are thankful to our MMC observer, Dr. Jairaj ji, who will be with us observing the program, the webinar, and all the attendees also for joining. At the outset, one or two simple housekeeping announcements. If you want a credit point, it's important to be logged in from the beginning to the end. So it will be recorded at how many minutes you have logged in, and then the credit points will be granted. Secondly, if you have any question or query, either at that time only put it in the chat box, which will be taken by the chairpersons to be asked to the speaker at the end of every talk and in the panel discussion. Or after the talk, you may be given a chance to unmute depending on the time that is available. But better will be that if you put it in the chat box, chairpersons and moderators can definitely take it. To begin,
Dr. Ameya, sir, sorry to interrupt you. Just would request all the delegates to put their queries and questions in the Q&A session. There is a separate Q&A session, so they can ask their question in the Q&A box.
okay, so please put your queries in the Q&A box also. There's a separate Q&A box that you can see on your own Zoom screen, and you can put your questions and queries as well as remarks there. It gives me a great pleasure to welcome two of my most brilliant colleagues who have worked hard to make this CME successful. And let me welcome Dr. Aasim Maldar, who is consultant endocrinologist at PD Hinduja Hospital. He has also taken certification from Royal College of Physicians. UK has multiple publications in international and national journals. And he's specially area interested in pituitary metabolic bone disease and transgender endocrinology. I am also happy to welcome my colleague, Dr. Chandni Seth, who is along with me attached to Bhaktivedanta Hospital and Research Institute, as well as has her own practice at Indra Group of Hospitals, Mira Road. She has trained in endocrinology at Gangaram Hospital, where she has been a faculty also and has also taken certification from RCP UK. She has been a speaker at various state and national conferences, and I hand over to Dr. Aasim and Dr. Chandni. Over to you.
Hello and good evening and a warm welcome to all the delegates. Osteoporosis is a silent disease, but when it makes a sound, it is the cracking of the bones. So according to the latest publications, according to the Indian publications done in 2022, the prevalence of osteoporosis in postmenopausal women is around 25 to 35%, while that of osteopenia creeps up to 50% of the postmenopausal women. Even men, the prevalence of osteoporosis is up to 15% or so. So these 1 in 3 women and 1 in 5 men globally will suffer from an osteoporotic fracture in their life. These fractures lead to increased morbidity, increased mortality. That is why it is very important to prevent, to diagnose and to treat these fractures early. World Osteoporosis Day was initiated on 20th October 1996 by the National Osteoporosis Foundation UK. And then later on, it became the annual high point of International Osteoporosis Federation. And since 1997, it is celebrated as World Osteoporosis Day. The theme for World Osteoporosis Day this year is Step Up for Bone Health. Step Up for Bone Health. So today we have with us esteemed faculty who are doyens in their fields of endeavor, and with them we'll proceed over the next few hours of teaching and learning, and hope everyone has a great time. I hand over to Dr. Chandni to introduce the moderators for the first session. Thank you.
Thank you, Dr. Aasim. Good evening, everyone. So we'll be having 2 sessions. We'll start with the first session where our chairpersons are Dr. Mohan Magdum and Dr. Neeraj Bijlani. Dr. Mohan Magdum is a senior endocrinologist in Pune. He is attached to Jehangir Hospital, Pune Hospital and Birla Hospital. Sir has been a speaker at all the prestigious national conferences, ESICON, RSSDI, MAPICON, etc. He has been an organizer of a very interesting yearly endocrine update at Pune. He has multiple publications in national journals, and he has been a principal investigator in many, I would say, revolutionary trials like EMPA-REG trial. And we also have Dr. Neeraj Bijlani, who's an orthopedic surgeon. He has OrthoTech clinic in Chembur, and sir has been a renowned teacher for all the orthos for tech related stuff, where he teaches everyone how to use the social media. And sir is a director for Ortho TV Global, which I also have watched a lot in COVID times. And sir is an honorary secretary of the Bombay Orthopedic Society. So I hand over the session to both the chairpersons so that they can invite the speakers further. Dr. Magdum and Dr. Bijlani.
Yes. I invite Dr. Milind Patwardhan. He is the director of the Diabetes and Endocrine Research Center from Neeraj. He is also the editor of Madhusakha, a patient-centered diabetes magazine, and the current president of the Maharashtra Endocrine Society, who is organizing this very wonderful event. Welcome, Dr. Milind Patwardhan.
Thank you.
Just to add a word, Dr. Patwardhan is my teacher from MD days and my mentor in endocrinology. So it is an honor to introduce Dr. Patwardhan. Sir's presidential address, please.
Oh, thank you. Thank you, Mohan. Thank you, Bijlani. Now, dear friends, on this World Osteoporosis Day on behalf of Maha Endocrine Society and IMA Mira Bhayender branch. I welcome you all for a feast before Diwali. Now, osteoporosis is a quantitative disease of bone, and osteomalacia, as you know, is a qualitative disease of bone. But in these days, we are seeing that osteoporosis patients also have a lot of vitamin D deficiency. It is a part of primary osteoporosis. So we have to consider that not as a separate disease, but as a part of osteoporosis. Now, as just now said, it's quite common disease, especially with the aging population now. About 25 to 30% of females above after menopause and 5 to 15% of the males up to 65 years of age will be having osteoporosis. So our job is to find out the clinical risk factors and certain investigations like bone mineral density scanning so that we can pick up those people who are at more risk of developing osteoporotic fractures. And once we find them out, we have to exclude some secondary causes like hyperparathyroidism, hyperthyroidism, vitamin D deficiency, as I said, even sometimes renal disorders or glucocorticoid drugs which patient may be taking for a long time. So secondary causes should be excluded. And after that, we have to see that the patient should be protected from developing the fracture. So lifestyle management, preventing falls, and then actual treatment of osteoporosis. So the most enthusiastic part of the discussion is that we have got now developing new drugs. We have got bisphosphonates for last 25, 30 years. We have got parathyroid hormone, calcitonin. But now we have got some antibodies also like denosumab. And the latest one is, I think, I have not used it, but I have read about it, romosozumab. So these new developments in pharmacology are definitely going to help to treat osteoporosis. And our job is to find out who is likely to develop osteoporotic fractures more and how to protect them. So luckily today, I highly appreciate that we have 5 orthopedic consultants today with us to share their views on how to manage osteoporosis, how to treat. Because the treatment doesn't end with the treatment of fracture. It continues lifelong. So we need to have dialogue between endocrinologists and orthopedicians. And that is what is going to occur today. So I welcome you all. I welcome all my orthopedician colleagues. And as Dr. Vikas said, that we don't want too much long discussion, but we want a dialogue to go on. We want discussion to happen. And I appreciate that suggestion. And I request all my colleagues to be to the point and give maximum time to the discussion part of it. So with this, I hand over the mic back to Mohan Magdum and Bijlani to start the sessions.
Thank you, sir.
Thank you, sir. We have very simple structure program here today. There are 3 talks in first session. First is about the diagnosis and evaluation of osteoporosis. Then it is a non-pharmacological intervention and treatment modalities. And then it is a pharmacological therapies. So first talk, Dr. Vaishali Naik, who is an endocrinologist from St. J.S. Medical College, KM, Mumbai. And she's consulted at Holy Family Hospital, Bandra, and Leelavati Hospital, Bandra. She is going to talk about the diagnosis and evaluation of osteoporosis. So let us get some insights from her. Dr. Vaishali, please.
Madam, you are not audible.
Vaishali, unmute karo.
She started, yeah.
मैडम आवाज नहीं है, वॉइस It's little less, madam. Thoda, if yeah, sound can be increased.
व्हॉल्यूम वाढवून बघा.
Is it fine?
Yeah, better, madam. If can be increased little bit, will be better.
Loudly.
Yes.
Good evening to all of you, and thank you for inviting me for this seminar. I'm going to speak on evaluation of a patient with osteoporosis. I'm sharing my screen. Can you hear me now?
Little louder if it can be. Yes.
Can you hear me now?
Yes, ma'am. This is better.
Okay. So I'm Dr. Vaishali, as he has already mentioned, I'm an endocrinologist, and I'm going to speak on the evaluation of the patient with osteoporosis. As you all know that osteoporosis is indeed a very significant public health concern now, and by definition, it is low bone mass with microarchitectural deterioration, which leads to fragility fracture. Now, the prevalence of osteoporosis is definitely increasing, and what we see in practice is just the tip of the iceberg. Approximately around 30% of all postmenopausal women have osteoporosis in the Western countries, and at least 40% of these women and 15 to 30% of men will sustain at least one or more fragility fractures within their lifetime. So what about our country? We have a population of 1.3 billion, out of which 230 million are more than 50 years of age. So what about them? So they're having studies from our country in which they have seen that 8 to 62% of women from all the age groups, they either suffer from osteopenia or osteoporosis at present. And among men also, it is no less. It is almost 8 to 25% of men more than 50 years who are suffering from either osteopenia or osteoporosis. So why is there a need to assess osteoporosis? One is there is definitely increasing prevalence. That is one, because there is increased awareness not only with the physicians but also with the population at risk. Secondly, the aging population is growing. Even if we say that 60 or 65 is, senior citizens, it is seen that osteopenia or osteoporosis can affect people at more than 50 years of age, or rather post-menopausal whenever they become menopausal. It's important to avoid fragility fractures in all our patients. The quality of life will improve if we prevent fractures in this aging population, and it will reduce the morbidity and mortality. It is known that almost there is a chance of 25% mortality in a woman who has sustained a hip fracture and needs surgery for that. So I'm just going to say some case scenarios that we see in our everyday practice. Sometimes a patient comes to us who is around 40, 45 years old. She has no medical or surgical issues. She's mother of 2 normal menses. She wants to assess her osteoporosis risk. So do we really assess her for osteoporosis? Or another patient who is a 59-year-old lady who is post-menopausal 5 years. She has a family history of osteoporosis. She has no fracture history, no other significant medical or surgical history. Sometimes we are referred with, like this one, who is a 62-year-old lady, referred from opinion for further plan of treatment. She had severe sudden onset backache and has sustained 2 fractures in the vertebrae. She is postmenopausal. She has been on steroids for rheumatoid arthritis for the last 10 years, and she is also on treatment for hypothyroidism. Many a times as endocrinologists, we do see patients who are admitted with fracture. So this is a case which I recently saw. He is a 72-year-old male admitted with left neck fracture femur. He is for surgery. He is a known diabetic on insulin. He had few episodes of hypoglycemia in the past. And during one such episode, he had a fall in his house and in the hospital. He had no knowledge of osteoporosis in the past. He had never been screened for osteoporosis as he is the male. And yes, it is not the age. We also see patients who are younger, 34 years old male who had a trivial fall followed by backache, and investigations have revealed osteoporosis on the X-rays, and he has been advised BMD. So do we really do bone mineral density in all these individuals, and how do we evaluate these patients? So to start with is to decide whom to screen. That is followed by history and clinical evaluation. Then we also evaluate the risk factors of developing osteoporosis and fractures. This can be quantified by doing the risk scoring method. This can be followed by biochemical and hormonal assessment, that is the investigation. And wherever possible, we should do DEXA, which quantifies the bone mineral density in our patients. And if required, some radiological assessment should be done in any patient who comes to us for the first time and asks us about osteoporosis or is referred to us for the same. At the same time, we should not forget the patients who are already on osteoporosis treatment. They also need a follow-up assessment. So who should be screened? So the National Osteoporosis Foundation has recommended that all women aged 65 years and older and men more than 70 years and older. Same time, postmenopausal women and men above the age of 50 to 69 years with some risk factor profile, or postmenopausal women and men over the age of 50 years who had a fragility fracture and who need to be diagnosed, and we have to determine the degree of osteoporosis to decide whether they need any treatment. Now we have our own society who looks after osteoporosis and metabolic bone diseases. That is the Indian Society of Bone Mineral Research. And they have observed that in India, it is the women or even the men, they have osteopenia or osteoporosis at an earlier age. And so the recommendations by the ISBMR is that the women aged 60 and older and men aged 65 and older, regardless of risk factors, should be screened. Postmenopausal women less than 60 years or men between 50 and 54 years should be assessed depending on their risk profile. Women in menopause transition, so they are not yet menopausal, but if they have a specific risk factor like low body weight or previous fragility fracture, or they have been on medications like glucocorticoids, then they should be screened even before being menopausal. Individuals who have fragility fracture even before the age of 50 years, and individuals who have conditions which may lead to secondary osteoporosis or on medications which can lead to low bone mass should be screened for osteoporosis. The most important part as a clinician is to take history before screening by any investigation, whether it is biochemical, hormonal, or even radiological. So when we speak to the patient, we have to look for modifiable and non-modifiable risk factors. We should check their exercise and activity patterns. The pregnancy and lactation history in women is very important. Calcium, vitamin D intake is very poor in our part of the society. Medical conditions which can cause osteoporosis should be looked into. Medications which may lead to bone loss. And not only this, but family history of these patients should be certainly looked into to decide whether they need screening. Many a times we see that patients come with fall history. Some of them do get fractures and some of them are saved. So fall history is very, very important. What is the underlying cause? Whether it is a fragility or it is hypoglycemia or it is hypotension, that has to be assessed. And the number of falls in the past also is important because that will predict future falls in a particular patient. Previous fragility fractures are also important to be noted in our history taking when we see these patients. Not only this, that when we put these patients on treatment, sometimes we do see that they do not respond to treatment. So what are the factors which may affect non-responsiveness of these patients? Now, risk factors for the primary osteoporosis are divided as non-modifiable and modifiable. The non-modifiable are age, sex, ethnicity, the peak bone mineral density that they have already achieved in adulthood, and the genetics. Whereas modifiable are nutrition, smoking, alcohol, exercise, use of medications. The secondary causes which can lead to osteopenia or osteoporosis are innumerable. So I have just put forth this chart in the nutritional, endocrine, drugs, and other hematological and rheumatic diseases which can make a person susceptible to osteopenia and osteoporosis, and not to forget certain inherited conditions like osteogenesis imperfecta. Coming back to history, the risk factor for fall should be taken into account, which can be environmental, like lack of assistive devices in bathroom, or loose throw rug, or low level lighting, or some obstacles in the walking path, which are very, very common causes of fall in elderly people. At the same time, neurological and musculoskeletal risk factors should be looked into, like kyphosis, poor balance, weak muscles, reduced proprioception, especially in diabetic patients. Medical risk factors should be considered in all patients who have presented with falls, anxiety, or hypotension in the past, poor vision, reduced mental acuity. They have urgent urinary incontinence, so they run to the bathroom in the night and then they have a fall. The medications which may cause over-sedation, which is used by many patients as they grow older, should be considered. Now, one has to think about obtaining history in order to select the appropriate treatment for a patient. So, high risk of breast cancer favors raloxifene use. If the patient has thrombophlebitis, then we will not use raloxifene in such patients. Patients who have peptic ulcer disease or esophageal stricture, it is a contraindication for oral bisphosphonate use. And somebody who has a skeletal malignancy, we of course would not try teriparatide in these patients. Also, factors contributing to suboptimal response to the therapy should be considered, whether the compliant and persistent to therapy is there, whether they are adequately taking the calcium and vitamin D. And if this is all normal, then we have to look back into history and investigations and think of secondary causes. Clinical examination is of course vital. In vital measures, we look for the loss of height, which may indicate vertebral fracture, loss of weight, thyrotoxicosis, very common, subclinical thyrotoxicosis, common in aged people, which is not picked up. Malabsorption, malignancy can present with weight loss. In patients who are on exogenous glucocorticoids, not for chronic diseases, but for some skin issues, may also present with dry acne and exogenous Cushing's, and may present with osteopenia, osteoporosis. Then in children, when they present with osteoporosis, we have to look at cranial dysostosis, which rarely is presented as hypophosphatasia. Look at blue sclera for osteogenesis imperfecta. Check the hearing in these patients. Then look for anosmia in patients who have come with hypogonadism and detected to have Kalman syndrome. Dentition assessment or dental assessment is very important, because those patients who are put on bisphosphonates, they have increased risk of osteonecrosis of the jaw. And not to forget our thyrotoxicosis, subclinical, clinical, which has high susceptibility to developing osteopenia and osteoporosis. Those patients who have COPD and have been intermittently on steroids should be assessed. Patients who have aortic insufficiency may have underlying marfans, so marfanide habitus has to be looked at. Musculoskeletal, some patients come to us with kyphosis, which is suggestive of multiple vertebral fractures, or if they have acute spinous tenderness, then they may have an acute vertebral fracture. Or if the space between the lower ribs and pelvis is reduced, then they may have multiple old vertebral fractures. At the same time, patients who keep on complaining of aches and pains, tender bones, we have to look for osteomalacia in these patients. Patients with chronic liver disease may present with hepatomegaly. Also, those who are on cancer chemotherapy due to the cancer or infiltrative diseases, they can have hepatomegaly. Should not forget vitamin B deficiency, the soul and whole of osteopenia in our part of the country, and they can present with muscle weakness, proximal myopathy. Rheumatoid arthritis, very common. The treatment and the disease itself is susceptible to osteopenia as well as osteoporosis, and rarely Ehlers-Danlos syndrome, which is a genetic syndrome, may present with hypermobility of joints. Neurological assessment is important in patients to suggest to look for poor balance, dementia in these patients, and those patients who present with hypogonadism, we should check for testicular atrophy. Once clinical examination is done and we suspect that the patient has primary osteoporosis or secondary osteoporosis, we decide the investigations. But routine investigations, which should be done in all patients who present to us with osteopenia or osteoporosis, are PBC, calcium, phosphorus, alkaline phosphatase, albumin, LFT, renal function test, thyroid, TSH for thyroid, vitamin D, and PTH. And special investigations depend upon what we are suspecting, and at least a routine protein electrophoresis, ESR, transglutaminase antibodies, testosterone, prolactin, overnight dexamethasone suppression if we suspect Cushing's in patients, and of course never to forget sugar test and A1C in our diabetic patients. So simple blood count can tell us about anemia, which may be due to malnutrition or myeloma. High ESR is seen in myeloma. Calcium, if it is hypercalcemia, it can be due to primary or secondary hyperparathyroidism or renal failure or Paget's disease, or even vitamin D intoxication. Hypocalcemia may be seen in vitamin D deficiency and hypophosphatemia, so they may present with osteopenia. Phosphorus also tells us about renal failure, whether the patient has been on bisphosphonate therapy. Hypophosphatemia is seen in primary and secondary hypoparathyroidism, and the more rare in osteomalacia and X-linked osteomalacia. The remaining investigations, alkaline phosphatase, if high, then it may suggest osteomalacia or Paget's disease, and low values occur in the rare hypophosphatasia. Vitamin D, as Seth said, is most important. Evaluate vitamin D in every patient. They may have secondary hypoparathyroidism, and once we treat vitamin D and calcium, the patient can have a normal BMD in later times. The creatinine assessed for chronic kidney disease, for renal osteodystrophy, and also to assess whether which therapy can be given to them for the osteoporosis. TSH, excess thyroid replacement, if somebody is already on hypothyroidism treatment, and because high bone turnover is known to occur with hypothyroidism, to assess for hypothyroidism. Chronic liver disease, we should do the liver function test. Urine tests are basic urine analysis may also point out to proteinuria, may point out to multiple myeloma or some chronic kidney disease, and abnormal cells may also suggest some kidney disease. 24-hour urinary calcium is done usually with patients on with renal stones, and elevated levels are taken as 250 for 24 hours in women, 300 for 24 hours in men, or 4 milligram per kg in either sex per day. So hypercalciuria, we have to rule out secondary causes, but the most common cause is idiopathic, and they can also present with osteopenia or osteoporosis. If at all urinary calcium levels are done, and if they have a low calcium excretion, which is less than 50 milligram, and they do not have any other disease, then silent celiac disease can be picked up if they have no other malabsorption syndrome. Coming to bone turnover markers. These are non-invasive laboratory tests which are done by serum and urine estimation. They are now readily available in clinical practice. They don't help in the diagnosis of osteoporosis or determine the cause. And in research, they have been done to understand the pathophysiology and also the mechanism of action of the treatments which are used in osteoporosis. In clinical practice, bone turnover markers offer the potential of predicting fracture risk independently of bone mineral density, and some societies recommend that we can start doing them at the onset of therapy also. But majorly, they are useful in monitoring the metabolic effects of therapy. A decrease and magnitude of reduction in these markers with anti-resorptive therapy help us to predict subsequent increase in the bone mineral density and reduction in fracture. And at the same time, in patients who are on teriparatide, an increase in bone turnover markers helps the prediction of subsequent increase in the bone mineral density. The markers of bone resorption are NTX, CTX, deoxypyridinoline, and pyridinoline. And bone formation markers, which can be measured in serum, are the bone-specific alkaline phosphatase, the P1NP, and osteocalcin. CTX is the bone resorption marker, and P1NP is the bone formation marker, which is advisable to use in patients who are on treatment with for osteoporosis. So there are certain limitations. I won't go in detail. Some of them are uncontrollable, like age, gender, menopause, or coexisting diseases. What is controllable is when do we collect the sample, whether the patient is fasting, whether he has done any exercise. The analytical sources of variability are how the specimen is processed in between laboratory variability. So if we ask the patients to do bone turnover markers, then we should ask them to do it from the same laboratory at the same time of the day and at probably the same time of the year after a few months. The reference ranges of these markers are not well established yet. So the National Osteoporosis Foundation recommends that samples should be collected early morning after an overnight fast. And another strategy to use these markers is to monitor the patients on anti-resorptive therapy is to use the absolute value. I'm sure the next speakers will tell us more in detail about this. Now, after doing clinical evaluation and investigations, not all patients can do a DEXA scan. It is still not available in all places in our country, and it is still it is not still quite cost effective, so it is costly for our patients. So BMD by DEXA is the gold standard to evaluate osteoporosis, and the BMD machines recommended by the WHO are 10.8 per million. And as you can see here in India, we have only 0.26 per million. So we are in dearth of machines, whereas other Asian countries have probably excessive for their population. So in these patients, we have to assess these patients and we have to use alternate risk assessment tools. So going by the previous history and investigations, there are simple questionnaires which are available, and these have to be filled up and then assessment. And these tools can circumvent the disadvantages of the high cost and the lack of availability of DEXA machines in our country. The most common and the most used is the FRAX. It is an online tool. It was developed at University of Sheffield, and it was developed by analyzing 60,000 men and women. The usage of FRAX in initiating treatment, however, varies from country to country. It has not been validated in many countries, including India. This is how we get it. It is available online. You can do it when you're assessing the patient, and you have to fill in the questionnaire. And particularly, even if you see there is a T-score, we do not need to add BMD or T-score for patients, and we can still get a risk factor from this tool. So that is stratification. Is if the FRAX is less than 10% for 10-year major osteoporotic fracture, then it is low risk. If it is 10 to 20%, it is medium, and more than 20% is high risk. Type 2 diabetes patients we see lots, and they pose a unique challenge in bone mineral density assessment. And we have seen that they have paradoxically normal BMD, but they fracture earlier. And so Leslie et al. Proposed 4 methods which can improve the performance of FRAX. So in that, 2 are substitution of the rheumatoid arthritis input by diabetes mellitus and by increasing the age input by 10 years for those patients. If we have bone mineral density done, then we can use a trabecular bone score or we reduce the femoral neck T-score by 0.5 SD when we enter into the FRAX. So are there risk stratification tools in India? Yes, there have been studies which have evaluated these different tools, OSTA, ORI, SCORE, bone and more. And the ISBMR recommends that we can use OSTA for primary osteoporosis. And in men, they have said that the more tool is useful for risk stratification. So they are readily available, inexpensive, easy to perform, technical expertise is not required. Validation is done in few centers, but however, they do not replace the need for a DEXA scan. And it is, of course, imperative to have a thorough clinical examination and history and investigations for all our patients. Radiological assessment, we cannot forget the standard X-rays. They are used to diagnose fractures of all types, and sometimes they can help us in finding out if there are secondary causes. The orthopedic surgeons can tell us more about the Gannett semi-quantitative method. This is for the visual grading system for vertebral fractures, and it can be also done by the vertebral fracture assessment on a DEXA machine report. Now, in patients who have primary hypoparathyroidism, they can present with bone cysts, as you can see here in the B, or they may have subperiosteal resorption, as it can be seen in these phalanges, or they may have brown tumors or saltpeter appearance of the skull. So these are pathognomonic of primary hypoparathyroidism, and these patients can present with osteopenia or rather osteoporosis. So here is a good OFC which is seen in a PHPT patient. Also, we should not forget osteomalacia patients present with aches and pains. And if we do their pelvis with both hips, we will see so many looser zones. And treatment with vitamin D and calcium really helps these patients. MRI, CT scanning, nuclear imaging may be used. MRI of the spine is commonly used prior to vertebroplasty or kyphoplasty. Now, coming to estimating the bone mineral density, we have various methods. I'm going to speak only on the DEXA today. It has a diagnostic classification. It measures the aerial BMD. QCT also has a good diagnostic classification, and it measures volumetric BMD. So it tells more about the bone content of the bone. The prediction of fracture risk is good for both DXA and QCT. However, the ionizing radiation in DXA is much less than QCT, and of course also the cost. And monitoring changes over time can be done in both the ways of osteoporosis evaluation. There are full DXA systems available, which we call the DEXA machine, and peripheral DXA systems are available to assess the calcaneal bone. In the full table system, they will assess almost any skeletal site, and what is the lumbar spine, proximal femur, forearm, and the total body. So most full table DEXA systems are able to perform additional scans also. So they give us information about the lateral spine BMD measurements. They give body composition study. They can assess vertebral fractures by the vertebral fracture assessment method, and they can also assess bone around the prosthetic implants. In children and infants who come with fragility fractures, there are special pediatric softwares available, and the radiologist can help us in finding if these patients have osteopenia or osteoporosis. So I'm not going in detail, just a few words. The DEXA systems initially used pencil beam geometry and a single detector, but now they use fan source and multiple detectors, so there is a decreased scan time and there is a decreased radiation exposure. These fan beam systems either use a single or a multi-beam mode. So what is measured? The bone mineral density is the measured parameter. In this, the bone mineral content in grams and the two-dimensional projected area in centimeter square of the bones is measured, and the BMD values are given in gram per centimeter square. But these are not used for diagnosing osteoporosis. What is used is the T-score. So these are usually how we get the report. This is for the spine and the hip and the forearm. So T-score is calculating using the formula, the patient's BMD minus the young normal mean divided by the standard deviation of the young normal, whereas the Z-scores are calculated similarly to the T-score, but here it is the age-matched normal mean which is used. And the results are expressed as standard deviation score. So you all know this, the World Health Organization criteria. I'm not going in details about that. What is important is younger age group, we use the Z-score, we assess X-rays if we are in doubt, and vertebral fracture assessment through the DEXA machine report is very useful for patients who present at younger ages for osteopenia or osteoporosis. Plus, patients who are premenopausal women, a low Z-score below -2 is suggestive of bone fragility. By the International Society of Clinical Densitometry, the site of measurement which should be used is the posterior anterior spine and the hip. We should not use the lateral spine. We should not use the Watt's triangle. The femur, the neck, and the total hip are the optimum site for predicting the risk. But when we are monitoring the response, most of the clinical trials have used the spine. In patients who are very obese, those with primary hypoparathyroidism, or in those whom they cannot measure hip or spine, then we have to use the forearm, that is the distal forearm, and usually it is the non-dominant arm forearm which should be used. This is how the machine looks. In order to interpret a scan, we have to first identify that it is of the same patient, the date of birth, the gender, the ethnicity, whether the positioning of the patient is proper. So for spine, it should be straight on the table. It should not be rotated. And the scan should extend up sufficiently far to include part of the lowest vertebra with ribs, that is T12, and low enough to show the pelvic brim, which is usually at the level of the L4, L5. Whereas for the hip, the patient's knees are elevated with a foam block, and that tries to partially flatten the lumbar lordosis, which is normal. And for a proper positioning of the hip, they give an internal rotation of 15 to 25 degrees. So this is how a correct positioning analysis scan looks. The spine region of interest is L1 through L4. Correct placement of the top and bottom of the spine box is very critical. We have to assess that. And there must be sufficient soft tissue on both sides of the spine. The hip region, regions of interest are femoral neck, trochanter, and total hip. And the preferred position for the rectangular femoral neck width differ for lunar and hologic. Careful checking of the femoral neck box is mandatory when we assess these scans. The image should be evaluated for artifacts. Spinal degenerative changes can elevate the spine. So we may have an old lady who has degenerative changes in the spine. We get a hip which is showing osteoporosis, and the lumbar spine is showing, in fact, normal or higher BMD. So in that case, we look degenerative changes. In the spine, when absent bone or some laminectomy or spina bifida is there, or there is a vertebral rotation, then there will be spuriously lower BMD. Vertebrae that are affected by local structural change should be deleted from the analysis. Usually 2 vertebrae are required for determination of BMD, and use of single vertebra is not recommended. Then the result is to be written as invalid. So concordance between measurement sites is not always possible. So many a times we see that the DEXA at the lumbar spine and the proximal femur do not match, and this discordance makes us think that maybe the report is wrong. But this is quite an observation in almost all patients who come to us with osteoporosis. So let's see why there is discordance. So first is physiological discordance because of the mechanical strain. Example is dominant hip and non-dominant hip. So dominant hip will show a better BMD than non-dominant. And between the spine and hip, usually the start out with different T-scores. The spine is said to reach a peak at least 5 years before the hip. And bone loss, when it is age-related bone loss, it is supposed to be more rapid and more importantly seen in the trabecular than the cortical bone. Trabecular bones, typically of the lumbar area, are known to have a rapid rate of deprivation in early postmenopausal state in comparison to the cortical bone. Now, what are the pathophysiological discordance causes? So, it is seen secondary to a disease. So, common examples are in elderly when they have vertebral osteophytosis, vertebral end plate facet sclerosis, osteochondrosis, or they have aortic calcification. In younger patients, ankylosing spondylitis may present with a normal or high BMD at the spine and normal or low BMD at the hip. Abnormal calcium deposition should be looked at when we are looking at the region of interest in these reports. Now, true discordance between the lumbar spine and the hip is usually seen in secondary osteoporosis like glucocorticoid excess, hypothyroidism, malabsorption, liver disease, rheumatoid arthritis, which affects spinal column much before and higher than the hip. And its discordance is due to the different composition of the bones, and that can be natural. However, artifactual discordance is important, so we rule out any metal from the zipper or the coin for any metabolic object. Of course, technical discordance is important. So device errors, technician variability, patient movements, variation, this all can be prevented by doing the least significant change when the patient comes back to for an assessment. And one very important thing is we have to tell the patient when we put them on treatment to return to the same BMD radiologist, or this machine should be used to recheck the BMD when there is a follow-up. So with respect to positioning error, it has been seen in various studies that at least 10% difference is seen with correct positioning. There is a betterment of the bone mineral density. Technical discordance can also because of wrong normative reference data, which is used in the DEXA scans. So these are a few of the scanning problems. The first is the lumbar scan, and the spine is too close to the right side, so it is not midway. The second is, if you see there are ribs, so it has not been identified properly, the lumbar vertebrae. The third is where there is a clip or a button, and so you can see a white mark there. The fourth, that is the D, there is an osteophyte, so it may predict a little higher BMD. And the fifth is a patient with laminectomy. So they will give this scan may tell us that the lumbar BMD is much lower than the spine. Now, hip scanning problems are also seen. And as you see in the A, the scan did not go far to include the femoral head. The B scan, the femur is too much adducted. The C is showing that it is too much abducted. So how do we know that it is in proper internal rotation? So the lesser trochanter should be seen the minimum. So in this D, if you see the lesser trochanter is seen a little bit too much. So it is suboptimal internal rotation. So these are things which we have to see on the scans when we assess the reports. And as you can see in the E diagram, there is abnormal bone. So there is history of hip fracture. So ideally, we should not take this side of the hip BMD. We should assess the other hip. Now, finally, physicians must keep in mind to actively look for secondary osteoporosis if there are very low BMD values by thorough history taking and investigations. Now, a little bit about trabecular bone score. It is a textural index that evaluates pixel gray level variations in the lumbar spine DEXA image, and it is usually used in evaluation of fracture risk in type 2 diabetes patients or primary hyperparathyroidism. This is how the scan looks, and there are cutoffs which are proposed for postmenopausal women, and they tell us about whether the bone status is normal, partially degraded, or degraded bone. Vertebral fracture assessment is very important. The ICD has stated that vertebral fracture imaging is indicated if the T-score is less than -1.0 and one or more of the following present. So the woman is more than 70 years, or the man is more than 80 years of age, or they have a historical height loss of more than 1.5 inches, or they have previous undocumented vertebral fracture, or they are on glucocorticoid therapy of more than 5 milligrams of prednisone equal to or more than 5 milligrams for more than or equal to 3 months. This is how the scan looks. And a bone biopsy rarely done in patients in clinical practice, but it can be done for evaluation of renal osteodystrophy, infiltrative disorders of bone, or in patients who are on treatment for osteoporosis, but they are not responding to therapy as expected. So for follow-up patients, again, clinical assessments, X-ray spine or femur, if they have pain in either of the femur, to look for atypical femur fractures. Dental evaluation is a must in these patients. Bone markers are useful for assessing the recovery or predicting recovery much earlier than the bone mineral density. And of course, other tests for underlying conditions as mentioned before. So the last slide is this. These are guidelines for clinical use for bone turnover markers. Separation of bone biochemical markers of bone turnover after 3 to 6 months after anti-disruptive therapy is seen and shows good response. Biochemical marker increases after 1 to 3 months after anabolic therapies are predictive of better BMD responses and better fracture risk reduction. Biochemical marker changes must exceed the least significant change in order to be clinically meaningful. Failure to achieve a change in bone turnover markers is a cause of concern. So if we are assessing the bone turnover markers and there is failure to change, then we should evaluate whether the patient is taking treatment properly or there is some other problem. Use of bone turnover markers allows assessment of the drug effect sooner than the DEXA because it can be done within 3 and 6 months. And also it's important that there is a regular contact with the healthcare provider. So when patients are on yearly zoledronate or smantizumab, they lose to follow up also. So when we do bone turnover markers, the follow-up compliance is better. So clinicians who are familiar with the benefits and limitations of these markers may find them as a helpful tool in the managing the patients with osteoporosis. Thank you very much. Hello.
Dr. Bijlani, Neeraj.
Sir, there are some questions.
At least there are no questions in the question answer box.
Yeah, I'll just tell them.
Okay.
Are oral contraceptive pills associated with osteoporosis?
Sorry?
Are oral contraceptive pills associated with osteoporosis?
No, oral contraceptive pills. In fact, HRT was previously used for improving the bone mineral density in postmenopausal women.
And what is the role of regular walking in maintaining the BMD?
Of course, I think the next lecture is on how to prevent.
The next couple of questions are targeted towards
the next lecture.
Maybe.
I would like to say that yes, of course, regular walking exercise will maintain the bone mineral density much better than no exercise.
I think, madam, I would like to request you to give one take-home message that many times patients come and in World Osteoporosis Day, a lot of companies did those heel pad screening and
Yes.
patients are coming with those reports. So should that be advised, or it should be like the patient should be given a prax assessment and then sent for a BMD?
Yeah, so according to me, I don't believe in the calcaneal assessment. So I would do a frac score and then if required BMD. In our city,
I think that is an important take-home message because our sponsors are also there and they have been sponsoring those BMD camps. So I think important thing that
but Dr. Ameya, I would like to say that the other osteoporosis societies, they do say that at least a calcaneal screening is done. It is better than nothing. So if patients don't want to do anything, at least do that. They say, but if in a city like Bombay where all of us are available, then better to do the best for them, right?
Yes.
I think the calcaneals can work as a screening tool, and we should not depend
use it as a diagnostic
on it. Yeah. We should evaluate the person further.
One last question is regarding role of proton pump inhibitors in osteoporosis.
I don't know the answer. Sorry. I think it will interfere with the the osteoporosis treatment. It is not given as an osteoporosis treatment, and they will definitely interfere with the bisphosphonate therapy which we are giving. And if anybody is on those,
yes, I have read.
Another thing is with proton pump inhibitors, the calcium carbonate absorption is affected. So, that's
they
why
have to keep a difference.
One could think of using citrates.
Yeah.
Dr. Ameya Joshi, can I ask one question? Dr. Aditya Kashikar here.
Dr. Aditya, please.
Yeah, as a orthopedic spine surgeon, should we ask always frac score first and then proceed to DEXA? Or we can, because usually in our practice, we directly ask for DEXA scan.
So in your practice, the patients come with a fracture, then we don't really need a frac score, or most of us say that we don't even need a DEXA to diagnose. Okay, so anybody who has a fragility fracture has osteoporosis, which is taken for granted. But however, to document, because we are going to put them on treatment, then we can do a baseline bone mineral density.
No,
frac score will be of no use if the patient is already fractured. No?
Yeah. No, my question was pertaining to patients who are elderly, around 60, 65, let's say, and they have just come for back pain, and during the usual evaluation, we see they have got gross osteoporosis on X-rays.
Right.
In
so in these patients, one is I would do the frac score and bone mineral density both.
Okay. Thank you.
Dr. Vaishal, there is another question about hypothyroidism associated with osteoporosis. Is it?
So hypothyroidism, usually the bone density is slightly better, but the treatment of hypothyroidism, that is thyroxine, if there is factitious thyrotoxicosis, so in patients who are over-treated with thyroxine and they become thyrotoxic because of treatment, then they have high chances of developing osteopenia or osteoporosis. So we have to tell them to at least their TSH every 6 monthly and maintain.
So basically, we should avoid overcorrection of thyroid treatment. Hypothyroid. And what is your opinion? Which calcium salt is best?
Calcium gluconate is best, but calcium citrate in certain individuals who have acidity, but I use calcium carbonate also.
What about, hi, this is Neeraj Bijlani. What about patients who have kidney stones? How do you basically, a patient who already has a kidney stone in place, recurrent kidney stone, especially like the elderly patients, sometimes they come with recurrent kidney stones. What should be given in that?
So what should be given means treatment?
Means which type of calcium? Is there a specific type of calcium? Because the pharma companies promote that you should give calcium.
I think Dr. Pitale is going to tell us that.
No problem.
But I think for if they have recurrent renals, one moment.
Yeah, we should definitely look at the urinary calcium excretion in that.
Yeah. So we should rule out hypoparathyroidism first thing. And as I had told in my slide, idiopathic hypercalciuria is very, very common. So also in these patients, if we want to supplement calcium, then in that case, if their urinary calcium is high, then we should not supplement them with calcium treatment. And I think any type of calcium would be fine.
Yeah, and I think in that situation, calcium citrate would be preferred over carbonate. And again, the oxalate excretion needs to be seen. If there is, by giving carbonate, sometimes you find that the oxalate crystals are made more and the risk of renal calculi increases.
Ma'am, one more question, Dr. Aditya Kashikar here.
Yeah.
Usually in patients where we have done fusion surgery, where implants are there, so usually DEXA is giving false value in those scenarios. So for such patients, if at all I really want to know the follow-up DEXA scan, or means, so which way we should monitor their osteoporosis?
So if it is a spine surgery, then if there is a fusion surgery done, then you will have to use the hip.
Okay, so we can rely on hip scores and accordingly we can. Okay.
Yes. Then we cannot rely on the spine score.
Exactly, because that gives false value.
Yeah.
Thank you.
Well, that was a brilliant talk by Dr. Vaishali Nayak, and she took us through all the parameters of diagnosis and evaluation of osteoporosis in just 40 minutes. Wonderful. And Dr. Neeraj, you
I have exceeded my time.
Yes. So I invite Dr. Shailesh Pitale for his next talk. He is the consultant endocrinologist in Nagpur. He is also the honorary associate professor as IGG Medical College since 2017. And he has been the president of the Diabetes Association of India, Nagpur branch 2011 to 12. Besides that, he has got so many publications, book chapters, and he has won a lot of international awards. His main area of interest is insulin resistance, obesity, thyroid disorders, and pregnancy. So with this, I hand over to Dr. Shailesh Pitale to please kindly share his screen and his talk.
Thank you, Dr. Bijlani, for the kind words of introduction. And I would definitely like to take this opportunity to thank Dr. Patwardhan and Ameya for giving me this opportunity to be on board today. So Dr. Vaishali has already set the ball rolling and discussed about the basic aspects of evaluation of osteoporosis. And I'm going to talk on non-pharmacological management of osteoporosis. I hope my screen is properly visible and I'm audible.
Yes, sir, very much.
Okay, so in next half an hour or so, I'll be talking about the non-pharmacological management of osteoporosis. And before we go on to the non-pharmacological management, which Dr. Vaishali has enumerated some aspects, we would discuss some aspects of bone physiology which would help us understand why this non-pharmacological management is important. So this definition was mentioned by Dr. Vaishali about osteoporosis. So when we look at the bone, it is the bone quantity as well as the bone quality which is important. So it is the amount of bone mineralization, the amount of bone density, and also the architecture which is important for maintaining the bone strength. And to maintain the bone quantity and quality both, there are certain factors which are responsible. And this concept of peak bone mass is very important to understand how we can prevent osteoporosis. These non-pharmacological aspects would also help us to prevent the development of osteoporosis and also be important in the management of osteoporosis along with the pharmacological management. So looking at the peak bone mass, we all know that in both men and in women, the bone mineral density keeps on increasing in the young adulthood and reaches a peak by around the mid-20s in both men and women. And over a period of time, it remains static till the time it starts declining very rapidly in women at the time of menopause. This dots on the x-axis indicate every decade of life, and you will find that at around 5th decade, the bone mineral density falls significantly because of menopause. And then once it goes down below the osteoporosis threshold, the osteoporosis sets in. So in first 5 to 10 years, 5 years, there is a rapid decline in the bone mineral density. While in men, there is a gradual decline over a period of time. Now, the importance of this peak bone mass is if you can achieve maximum peak bone mass during your young adulthood, you would prevent, or it would be a preventive step towards getting into osteoporotic range or getting into below the threshold of osteoporosis. So, to have a good peak bone mass, it is very important to pay attention to certain factors. We know that peak bone mass is determined by certain genetic and racial factors, hormonal influences, and most importantly, it is the nutritional factors, the lifestyle, the sports, the diet, all those things are important. And that is where the non-pharmacological management would come into play. So this was enumerated by Dr. Vaishali Naik in her talk, the risk factors for osteoporosis. There are certain groups of people who are at high risk, and there are certain factors which increase the risk. The ones which mentioned in yellow are the non-modifiable risk factors. And the ones which are mentioned in white are the modifiable risk factors for osteoporosis. So factors like alcohol abuse, smoking, sedentary lifestyle, the lifestyle-related issues would significantly lead to increased risk of osteoporosis. Now, dietary calcium and vitamin D deficiency predisposes the individual to low peak bone mass if it is during the young adulthood, and if that carries over during adult life and old age, the risk of osteoporosis increases significantly. So when you look at the non-pharmacological approach to prevention and management of osteoporosis, it is importance is of physical activity. We'll look into the details of that. Adequate calcium intake, good protein diet, good vitamin D intake, minimal alcohol intake, and the risk of fall needs to be assessed. And of course, this aspect of hip protectors and these things would be dealt with more by the orthopedic friends of ours. So when you look at the importance of physical activity, it is extremely important right since childhood. And we know now that in today's society, the children are more glued to indoor games and are less commonly seen on the play field. And this definitely is going to affect the bone mineral density and the peak bone mass of this new generation. So having a good physical activity during growth increases the bone strength and peak bone mass. During adulthood, it helps to maintain the bone strength and the muscle strength. And during old age, exercise attenuates the physiological decline in the bone mass, which we saw in the previous graph. So if an elderly person is physically active, it would attenuate the decline in the bone mass and help to preserve the bone mass. So when you look at the exercise, regular weight-bearing exercises are important. When there is a lack of physical activity, the bone mass will be low. Bone loading exercises, the weight-bearing exercises would definitely have a beneficial effect on the bone mass. Now, static weight-bearing exercises, these can reduce the decline in the bone mass and improve the bone mass in people who are elderly, who are above the age. So in people, and we need to tailor the exercise as per the person's age. You can't ask a 60 and 70-year-old person to jog if he's not used to. So certain weight-bearing exercises would help them. High-impact exercises in early life definitely help the peak bone mass. So we should encourage the younger population, the children and young adults, to be active, to play some games, so that these weight-bearing exercises with adequate calcium, proteins, and vitamin D would help to increase the bone mass in young age. Now, there are certain exercises, the balancing and strengthening exercises, which would help to reduce the risk of fall, like the Tai Chi and the Otago exercises, which have been tailored specifically to improve the balance. Now, regular weight-bearing exercises, the weight-bearing exercise is defined as those exercises in which the bones and muscles work against the gravity as feet and legs bear the body's weight. This would include walking, jogging, Tai Chi, climbing of stairs, playing games. Now, this improves the agility, strength, as well as balance. And the increase in bone density would help also to enhance, and these exercises would help to enhance the muscle strength and improve the balance. Now, when you look at the exercises, the high impact exercises are like skipping, jogging. They would improve the bone mineral density, and those are to be encouraged in the younger population. Low to medium impact exercises like step aerobics, intermittent jogging, these are appropriate for those who are not used to exercising since young age, and those who are in their 50s or elderly. In them, these light or low or medium exercises should be encouraged. Now, in patients with osteoporosis, any form of strength training should be site-specific. It is important. Now, if there is a patient who has osteoporosis, the specific muscle groups which will be targeted would be those around the hip, the quadriceps, the dorsiflexors. So the exercises have to be tailored based on the patient's evaluation. Now, weight-bearing exercises, as I mentioned, it should be load-bearing predominantly, and those should be gradually progressive in intensity and impact. And this progression of the intensity has to be very gradual. Otherwise, it can be detrimental and can cause injuries to the elderly people. The most important thing is persistence in being regular in this physical activity, and it has to be continued over a period of time. These are some of the exercises which are recommended, specifically like wide leg squats, standing leg curls, knee extension. Now you can ask the patient to put ankle weights when they are using knee extensions. These our orthopedic friends do advise majority of their patients with quadriceps strengthening and all. Hip side raises, biceps curls. The exercises down below would help the spine and the paraspinal muscles, which should be strong and would help in balance. So all these exercises have to be structured and should be specifically tailored to the individual person. Certain yoga positions are important. These yogas are important in improving the agility, the balance, and also weight bearing and improving the bone strength and the flexibility of the muscles and the balance. There are certain high impact exercises which need to be avoided in patients with osteoporosis. So patients who are non-osteoporotic, who have osteoporotic fractures, in them high impact exercises like jogging, skipping, jumping, these should be avoided. Excessive bending should definitely be avoided in elderly who have already had osteoporotic fractures. Activities which require twisting. Now there are certain exercises like this Salabhasan, which can cause problems if the patient already has got a vertebral fracture. So such exercises need to be tailored or rather carefully told to the patient. Certain weight-bearing exercises like squats, sit to stand, forward lunges, these are simple exercises and can be done by elderly people also with support. If they are having problem with balance, one should make sure that they are using proper support while doing these exercises. Now, moving on from the exercises and physical activity, another most important aspect is the calcium and vitamin D. And before we go on to the calcium and vitamin D supplementation, let's look at some of the bone physiology, which is important. So we know that bone is made of cells and extracellular component. When you look at the extracellular component of the bone, 35% is the mineral content and 20% is the matrix. Now, bone matrix contains protein, collagen, while the mineral, it is predominantly calcium. About 1 kilogram, 1,000 grams of calcium is present in the bone. Phosphorus about 600 grams and magnesium. So when we are talking about strong bones, we need to have proper mineralization of the bone, which would contribute to this 35%, and good protein bone matrix. So good amount of nutrition is important to maintain the bone extracellular compartment. Now, when you look at the calcium physiology, if we look at the calcium dynamics, if 1,000 milligrams of calcium is taken, the intestine would absorb about 350 milligrams, and basically it is the amount of calcium in the extracellular fluid which needs to be very intricately balanced. So to balance this, one, there would be absorption from the gut. Second, the bone reserve calcium goes in and out to maintain the proper calcium balance of the extracellular fluid. And the kidney plays an important role. We know that basically the resorption and excretion, the calcium excretion through the urine is normally not more than 100 milligrams. So basically, it's a balance between the kidney and the bones to maintain the extracellular level of calcium normal. So at any point of time when the extracellular calcium goes down, there would be absorption. But if the absorption is low for whatever reasons, either low intake or problems with absorption, the most important reservoir on which the body falls back is the bone. Bone is a high reservoir of calcium, and there will be bone demineralization to maintain the extracellular calcium level. And that is when many times the bone starts getting weak. When you look at the bone calcium, we know that about 10 to 20 grams is present in the interstitial fluid, which is exchangeable, and a majority of it, more than 980 to 990 grams, is present as stable reservoir. But you need to understand that this is affected by certain factors like osteoclast stimulating factor and endocrine factors like the parathormone. Now, if you have a situation where there is calcium deficiency, vitamin D deficiency, which leads to secondary hyperpara, PTH is elevated, and that elevated PTH will then take out the calcium from this bone store into the extracellular fluid and will decrease the bone mineralization, predisposing the person for bone demineralization and osteoporosis. So it's extremely important to have adequate calcium, adequate vitamin D, so that there is no stimulation of bone resorption from this reservoir. So dietary calcium, good diet is important for bone formation, and adequate calcium intake at all stages of life is extremely important, along with an active lifestyle. It is important through childhood, adolescence, and early adulthood to build up a good bone mass, as we have seen the peak bone mass, for which we need to have good amount of calcium. Now, some foods that may provide significant amount of calcium, but also contain substances which reduce the absorption. And those are like associated with whole grains, which contain phytates. Phytates would reduce the absorption of calcium. Oxalates, which are present in spinach, that can reduce the absorption of calcium. So that needs to be taken into account when the patient is taking calcium. Now, we all know there are nowadays in India also good number of people are turning to vegan diet. Now, vegans do not eat dairy products, and they should make sure that their diet contains sufficient calcium. So soya products, tofu, soya drinks, which are fortified with calcium, are available, and those should be encouraged. Now, this question was discussed was asked after the previous talk. Which calcium? So when you look at the calcium supplements, there are various calcium supplements available: calcium carbonate and calcium phosphate. Out of the calcium carbonate and calcium phosphate which is available, 40% is elemental calcium. In calcium citrate, it is 21% is elemental calcium. Calcium lactate is 13%. and calcium gluconate is only 9% elemental calcium. And when you take this orally, the absorption is about 20 to 30%. The calcium carbonate, even though it is 40%, the absorption is less. Calcium citrate, the elemental calcium is 21%, but the absorption is more towards 30 to 35%. Now, amongst these preparations, calcium carbonate is the one which is more easily available, more economical, but in some cases, it can cause GI discomfort, constipation. So in such situations, calcium citrate can be used in certain situations, like in achlorhydria, patients who are having inflammatory bowel disease, absorption problems, for patients on proton pump inhibitors who have some tolerability issues. Now, we all know that calcium absorption occurs when there is adequate amount of vitamin D, because vitamin D is very important for calcium absorption. Now, vitamin D is predominantly synthesized in the skin, and also one would get from the diet. It's very well known that dark-skinned people make less vitamin D, and we do presume that in our country there is a lot of sunshine. But if we look back and see how much sunshine we are exposed to, hardly any, because we usually won't be going out in the sun for significant duration of time to make adequate vitamin D. So we all have to be careful and need to look at the vitamin D levels. So good vitamin D status has also been shown, apart from the bone health, it has been shown to have a good muscle mass and muscle function, and has been shown to prevent fall in elderly people. The sources of vitamin D are fish liver oil, have been shown to have high vitamin D. Oily fish like sardine and all those tuna, these are good sources of vitamin D. Egg yolk is a good source of vitamin D. Liver and butter contains small amount of vitamin D, and there are certain foods which are fortified with vitamin D. Food fortification with vitamin D is not as common in our country as is in the Western world, but I think it is the need of time in our country that vitamin D food fortification should be an important thing which should be taken up and should be done for our population. Now, there have been studies where they have shown that adequate calcium and vitamin D supplementation significantly reduces the fracture risk in elderly when compared to placebo. So, by giving calcium and vitamin D, the risk of the hip and non-vertebral fractures is significantly reduced in elderly women. What is the recommendation for calcium and vitamin D? These are the recommendations of ICMR. Age-wise recommendations, if you see here, and for adults, it's recommended that for calcium 600 milligrams of elemental calcium and vitamin D about 400 units of vitamin D. Now, the level of sufficiency is mentioned here, but frankly speaking, I personally feel this is low, and if you look at the ISBMR recommendation, those are different. This is the position statement of Indian Society of Bone and Mineral Research, and it says that one should aim at maintaining the 25-hydroxy vitamin D level more than 20 nanograms per ml, and to do that, it is recommended that 1,000 to 2,000 international units of vitamin D should be given as maintenance therapy, and adequate dietary intake of calcium with a total intake, which would include diet plus supplement of at least 1,000 milligrams per day. And I think this is the most practical definition, or rather recommendation, for Indian population. Other dietary aspects which are responsible for bone health, it's been shown that vitamin K is also important. There are at least 3 vitamin K dependent proteins which are present in the bone, and impaired vitamin K status has been shown to be associated with low bone mass and increased risk of fracture in men as well as women. We know that vitamin K is present in green leafy vegetables, meat, and dairy products. Now, coming to sodium. Sodium and the relation with osteoporosis, it has been shown that excess sodium has a negative impact on calcium balance. Increased sodium intake leads to increased calcium excretion through urine. So obligatory urinary calcium loss has been shown to be correlated with urinary sodium excretion. For every 100 millimole of sodium excreted, there is approximately 1 millimole of calcium which is lost. So enough calcium in the diet could overcome these salt deleterious effects. And it has been very clearly shown in studies that diets which are high in sodium are related with increased urinary calcium excretion. So one should have advise the patient to have a low sodium diet, especially to prevent calcium loss through the urine. And there is a significant increase in PTH level, which has been demonstrated, and increased level of urinary N-telopeptide in patients who are on high sodium diet. So we know that when there is an increase in parathormone, there is going to be resorption of the bone, and the bone mineral reserve, which I explained to you, is going to be demineralized, and thus high sodium leads to all these factors and increased calciuria. Another factor is caffeine. High caffeine can lead to can predispose to osteoporosis, and the Birmingham study, which has a huge data on various aspects, has shown that the risk of hip fractures is increased, especially when the caffeine intake is more than 2.5 units of caffeine per day. And it is defined that 1 unit of caffeine is equal to 1 cup of coffee, or 1 cup of tea is equal to 0.5 units of caffeine. So if someone is taking more than 2.5 units of caffeine, it predisposes to osteoporosis. Caffeine, basically what it does is it increases the urinary as well as fecal calcium loss, and there is a negative calcium balance which is seen in patients who take high caffeine. Potassium has an exactly opposite effect of sodium. So potassium has protective effect on urinary calcium loss. So this positive impact has been seen. The positive effect is completely offset if there is a low calcium intake in the diet. So if you take fruits with high potassium and adequate calcium, you can decrease the bone demineralization. We know that soya isoflavones have been recommended and have been shown to have beneficial effects. Soya isoflavones are structurally and functionally similar to 17-beta estradiol, and the phytoestrogens act both on osteoblasts and osteoclasts through genomic and non-genomic pathway. Now, there has been this meta-analysis of about 1,200 postmenopausal women, and they showed that there was an increase in the spine BMD. However, there are certain other studies where there have been no significant benefits over a period of time, but the study group were different and the time frame where it was looked at was different. However, it has been seen that soya proteins or soya isoflavones, there is no significant effect observed on the femoral neck and the hip trochanter BMD. What the effect was seen was more on the spine BMD. Now, the lifestyle factors, tobacco and alcohol are absolute no-no. They have a significant detrimental effect on the skeleton. Excessive alcohol does have significant detrimental effect on the bone. Excessive alcohol causes it is a cause of secondary osteoporosis and a risk of fracture. It has direct effect on osteoblasts and indirect adverse effect on the skeletal system in terms of deficiency of calcium, vitamin D, increased risk of fall. And it's been shown that high alcohol consumption is non-linearly associated with increased fracture risk. Now, when you look at the ISBMR's general recommendation, the position statement of 2021, it does recommend that one should limit the alcohol intake to no more than 2 units per day, stop smoking, maintain an active lifestyle, and have a proper weight bearing and balance exercises. And counseling should be done to reduce the fracture risk, particularly in the older population. So this is an important aspect that we should consider, especially because our population is aging, and majority of the aging or elderly population, they are living on their own, the husband and wife, or alone, because their younger children are move out, and majority of these elderly people have to live on their own. So it's important to assess the fall risk We need to consider all these factors Dr. Vaishali discussed in her talk. We need to look at their gait, vision, nutrition, medical condition, pharmacy, footwear, factors at home, environmental factors. These are all very important, and definitely over a period of time, this is going to be important aspect of geriatric care, and we have to have a team to evaluate all these things. And it is important the team approach, multifactorial assessment needs to be done. In these elderly people, one needs to look at the mobility of the patient. All these various tests are recommended. Physiotherapists can do that. Medications have to be looked at. One needs to look at these aspects, the medication count, the kind of medication. I would like to mention here, like at my own home, my father, who is 83 years of age, about a year back, he had prosthetic symptoms. And he was started on an alpha blocker by the urologist, and he took the tablet at night post dinner. And in the middle of the night, around 1 o'clock, I got a call that he had a fall. So it was a first dose hypotension which he had. So in the elderly diabetic, he has diabetes, he has peripheral neuropathy. So in such situation, it can be catastrophic. So postural hypotension needs to be looked at, evaluated. One needs to measure for postural hypotension in the elderly people who are on multiple medications. Vision, foot care, environmental factors, these need to be looked at and have to be addressed. And I think it is time for us to develop a team which can look after this, and especially people who are into geriatric practice. It is very important to develop a team to evaluate all these things. And the last thing which I'm just going to enumerate but not discuss is hip protectors and vertebroplasty and kyphoplasty, which are also considered as a part of non-pharmacological assessment or non-pharmacological management of osteoporosis, which I'll leave it to our orthopedic friends to discuss about. So non-pharmacological management is nothing less important than pharmacological management. In fact, without these, the pharmacological managements may fail. So one needs to definitely pay attention to the non-pharmacological aspects of osteoporosis for prevention of osteoporosis and also for management of osteoporosis. Thank you very much. I'll stop sharing the slides here and we can discuss the issues and share the experiences.
Thank you, Shailesh, and wonderful talk. And the closing slide with landscapes that reminded me of the Russian painter, I think Royrik or somebody, who had a museum in the Kulu. Very beautiful. I believe those were your photographs. Dr. Neeraj?
It was from my collection, but it wasn't mine. I am not that good a photographer. It was, I think, my kids.
So, Dr. Bijlani, would you like to take over?
Yes. So let me see if there are any questions.
So while you're waiting, Neeraj, could I ask a question?
Yes, sir. Go ahead.
Great job, Shailesh. There was only one thing, just playing the devil's advocate. What is your thought on swimming as an aerobic exercise and swimming as prevention of osteoporosis?
Yes, swimming as an aerobic exercise is good, but it is not a weight-bearing exercise. So one needs to bear that in mind, that it is not a weight-bearing exercise, but it is very good for the back muscles, the spine muscles, and also for hip flexibility. So those swimming is good, but it is not good for increasing the bone mineral density. So one can do that. Swimming can be recommended for increasing the muscle tone, muscle power, paraspinal muscles, but not for BMD enhancement.
So there is one question. Which is the best time to take calcium supplements? Is it before or after the meal?
Calcium carbonate after the meal and calcium citrate, it significantly doesn't make any difference at any time of the meal.
Is there any role of zinc on improving the BMD?
Zinc, I am not aware. Manoj, if you want to highlight, I am not aware about zinc.
I think if anything, we should stress on the importance of adequate proteins in the diet. We talk of calcium and vitamin D,
Yeah.
But as Sailesh said, 35% of the matrix is proteins. So it's very
There is
important.
also one question about green tea and its role in BMD.
I am not aware. I think it is these nutraceutical products are promoted much more by the marketing agencies. But I am not aware of the science behind the green tea and BMD as such.
There is one more question on sun exposure and vitamin B sufficiency in kids. How much time and what time?
I do not know in kids as such, but if you look at the data, it says that at least 45 minutes to an hour of sun exposure, but the timing of sun exposure is also important. Many times we consider that early morning sun, people will go out for a walk early morning at 6 o'clock and 7 o'clock, and they would think that they're making adequate vitamin D, but that is wrong. The appropriate time as such, which is recommended somewhere between 11 a.m. to 3 p.m. So
Yeah, sun at zenith.
Yeah, so how many of us are in the sun with partially exposed bodies between 11 to 3? I think hardly none of us would be. So
And that has to be 4 hours.
No. Between those 4 hours for at least 45 minutes to an hour. Not for 4 complete hours, but at least for 45 minutes to an hour. So majority of us will not be exposed to sun during this time of the day. And if at all we go out somewhere between this time, it may be for 10 minutes, 15 minutes, we may walk in the sun, and then we may enter a building or somewhere else take shelter. So I think our sun exposure and sun making adequate vitamin D for us is not the practicals, or rather the situation in practical life.
Evolutionary,
yes, sir.
Yes, sir.
I just read that 20 centimeters of the skin exposed to this midday sun for 20 minutes produces 1000 units of vitamin D synthesis. And I think that is quite a good exposure, especially if you have something like me, you can easily get 20 centimeter exposure easily.
I think, Dr. Patwardhan, this is for the fair-skinned people, not us.
Yes.
Number one, I just wanted to add what Dr. Agashe will remember years ago, he had got a UV meter. And in some of the polluted areas of Mumbai, he had asked the policeman standing on duty to hold the meter for so many hours. And there is hardly any UVB light following in this, the Kurla areas and Parel areas. So this theoretical part is fine, doesn't work for us.
Yeah, and even I think there was a study done in Delhi or Lucknow in army recruits, where they looked at vitamin D levels in army recruits who are in the sun, in shorts and in banyan, exercising, and they looked at the vitamin D levels in these army recruits, and it was significantly low. So essentially in dark-skinned people, in we Indians, the amount of vitamin D made is not adequate. Again, there have been studies where they have shown, especially in Bangladeshis and Asians in UK, where they have shown vitamin D receptor problems. So even if we make, I don't know how much that is biologically effective. So definitely we need to have more than the Westerners vitamin D in our system to have good bone health, I feel.
Yeah, Hari Narayan from Tirupati
Yes.
on the South Indian farmers also showed that they were not as bad as the regular population, but still nowhere near normal. So our dark skin is a so-called protective mechanism so that the sun doesn't affect us.
I think if we look at
It's actually pouring in. One of them is about the calcium level. Should you measure it before prescribing calcium and vitamin D? And does your sunscreen interfere with vitamin D synthesis?
Yeah,
Yes,
sunscreen does interfere with vitamin D formation. Definitely, yes. Measurement of calcium is not recommended because, as I mentioned or showed you the physiology slide, to maintain the extracellular calcium level, even if your extracellular calcium level goes down, it is going to be pulled out from the bone reserve. So your calcium level in the blood being normal doesn't mean that you are calcium sufficient, because your bone is a huge reservoir. So you are demineralizing your bone. So I think adequate calcium intake is more important. It's not the level.
Yeah, but with the automation and the routine calcium being done in most biochemistry, we are worried about high calcium, not the low normal or normal calcium. Maybe rare, but it is significant.
There is a question twice that how much walk is adequate or recommended for bone mass development or protection?
The walk which is recommended is about 20 to 40 minutes walk for about 5 days in a week.
Can I ask a question, sir, with your permission?
Yeah, please.
Sir, what do you think about the route of administration of vitamin D? I mean, IM or
oral is, IM usually is not recommended unless until it's like severe vitamin D deficiency rickets where you give not more than a few shots, but otherwise no. Oral is good enough, and you can give, again, regarding the oral, we have 60,000 units available in our country. But if you look at the studies, I think, Manoj, if you could give your expert opinion, 1,000 to 2,000 units per day is much better than giving 60,000 units weekly or monthly.
So as a correctional dose, where you have vitamin D deficiency, you need to give mega doses. The daily doses, because we have done a study at Nair also, the daily dose will take months to correct the vitamin D deficiency. So what we are doing is, say, once a week for 8 weeks. Then you have the option. Yeah. So there have been some recent studies which looked at daily doses over the monthly doses.
And one more addition is that intramuscular dose doesn't quickly replete the serum vitamin D. It is the oral dose which actually is quickly absorbed, taken to the liver, converted to 25 and stored in the body. So intramuscular is not indicated nowadays.
Like Pratibha had shown this in her study also, that in contrast to the intramuscular, the oral injection
route is much better than intramuscular.
Much better.
Yeah.
In fact, there was this, if I'm not wrong, it was in KM only, right? They did the injectable ampules, they cut it and gave it orally. And it was seen to be better when given. Now we have all the oral preparations available, but before that.
Sir, any recommendations about active vitamin D? I mean, whether you would prefer to prevent or treat osteoporosis?
I think only in patients with renal insufficiency, CKD, one would recommend, but not otherwise.
Or hypoparathyroidism.
Hypopara, yes.
There are combinations, I mean, fixed drug combinations with calcium, vitamin D, and even vitamin K. So those are available commercially.
I don't think there is a significant recommendation regarding supplementation of vitamin K, even though commercially available preparations are available. But as such, recommendation-wise, there is no recommendation of having vitamin K along with calcium and vitamin D as such.
But patients often asks us that how long one can continue to take calcium.
Yeah, I think it is lifelong. I mean, you have to meet your daily requirement.
They always say कि डॉक्टर साहब 6 महीना लिया है, 2 महीने का गैप लेते हैं, बाद में तीसरे महीने से शुरुआत करते हैं. So they come with their own theories.
Yeah, in our country they have all their own individual thinking.
No, but I think we need to discuss this because there is no indication for oral calcium unless, as Shailesh said, there is definite calcium deficiency. Otherwise, dietary calcium will be best absorbed when you supplement vitamin D only. There is no need of calcium supplement.
We need to make sure that there is an adequate dietary calcium. If the dietary calcium is inadequate or there is deficiency, you need to supplement. And it's extremely important. Like, for example, I'll tell you, I tell my patients certain small things like, if you are having your tea, make a tea with full milk, do not put water. So instead of having little bit of milk and a glass full of water, if you like with milk, take as much as dairy products as you can. Have one cup of one katori of dahi with lunch and dinner, both. And once it becomes habit, I think they can get into it.
So regarding dietary calcium, to fulfill the calcium need, we may require at least 800 to 1000 milli of cow milk intake.
Yes.
Which would be literally impossible. And then leafy vegetables every day in a quantity that is also near impossible.
No, it is very difficult. I agree, Mohan, with you. And another thing is, in fact, I was discussing this with one of the guys from the milk factory. And when they talk about homogenization of the milk, I mean, I asked him, what is this homogenization? I mean, so he said when they get the milk, they get it from different sources. And when they mix that milk, it doesn't get mixed because the source is different. The density is different, the fat content is different. So to homogenize that, they put certain chemicals, even something like low quantities of urea, to homogenize that. Now, when they homogenize it, what is the bioavailability of the calcium in that? We really don't know. So I think what Mohan is saying is when we are getting pure milk, the bioavailability. When we are getting a homogenized packet milk, I don't know what is the bioavailability of that milk which we take.
Well, a lot of good discussion about vitamin D, calcium, and non-pharmacological exercises and all those. So let us move forward and next talk about the pharmacological intervention for treatment of osteoporosis. And to that, we have Dr. Manoj Chadha. Everybody knows him. He is a consultant at Hinduja Hospital. He was teaching faculty at KEM Mumbai, BOL Nair Hospital Medical College, and now for more than a decade at Hinduja Hospital as a DNP teacher. And interesting, he has training in artificial pancreas usage in Germany. To his honor, he was past president of Endocrine Society of India 1718 and past president of Indian Society of Bone Mineral Research in 2015 to 19. And he was past president of our Maharashtra Endocrine Society. So over to Dr. Manoj Chadha, sir.
Thank you, Mohan, and congratulations to the executive of Maharashtra Endocrine Society for getting all of us together. So let me start my... I think Vaishali and Shailesh have made things easier for me in the sense they have covered up a lot of things. So next 30 minutes or so, my emphasis is going to be on choice of treatment and osteoporosis, very quickly on the timely initiation of treatment. I'm going to, also talk a little bit on fracture liaison service, about which I'm very passionate, and I hope our physician colleagues, our endocrinologists, and especially the orthopedic surgeons who are a part of this should give importance to FLS. I'm not going to be discussing the importance of diabetes and osteoporosis in men. These are two things which are separate chapters. I don't want to dilute it by just touching it in my talk. See, we have heard about the diagnosis of osteoporosis. We talk about the BMD as a gold standard and osteoporosis being diagnosed beyond or below -2.5. But this very interesting study from Sweden had actually looked at the risk of fractures versus the fracture hip that was happening in postmenopausal women. And you see that the maximum fractures don't happen after -2.5. It is between, say, -1 and -2 or -1 to 2.5, because that is where the largest population of postmenopausal women live. By the time they reach -2.5 or -3, their risk of fracture has gone up, but the number of fractures has gone down. So it's very important for us to keep looking at the risk of fractures. And Vaishali told us about the various risk factors. She also gave you the how to look at these diagnostic tests. But what I want to say is that the risk factors for osteoporotic fractures is not the same as risk factors for low bone density. You see, so when you're looking at risk factors for osteoporotic fractures, you're looking at low BMD advancing age, there is no way you can change this or modify this factor. And I'm going to show you a slide how age affects the risk of fractures. A prior history of fragility fracture, nothing to do with what is happening otherwise. A family history of osteoporosis, again, very important. So I think Vaishali has stressed on it, and I'm again repeating it as a carry-home message that you must ask in your clinic about the paternal and especially the maternal history. Smokers, heavy drinkers, low body weight, obesity, falls, and sarcopenia, dementia. These are all risk factors for osteoporotic fractures individually, and when they're put together, they become a terrible combination. So as I was talking about age as a risk factor, so if you were to take this point as minus 2.5, there's a 12% fracture risk if you're about 50 years. But at the age of 70, that fracture risk doubles. So BMD is and should be only one factor that you look at, and you should look at the other modifiable and non-modifiable risk factors while you're deciding. Whether it's FRAX, whether it's OSTA, whether it's Garvin score, we need to start thinking about risk factors above the BMD numbers. We heard about these secondary causes for osteoporosis, especially if you have male patients. Because I remember as a student, I was taught you do not get osteoporosis in men. And if there is osteoporosis, then you look for a secondary cause. And that may not be true today because men are living also till 80, 90 years old. So they would get the regular osteoporosis. The red, would point towards higher incidence in men, steroids, alcohol, hypogonadism. The green would point towards higher incidence in females, thyroid hormones, hypercalciuria, malabsorption, celiac disease, hyperparathyroidism. Whether vitamin D deficiency is more often in women or not, we're not going to get into discussion. But the other conditions also Vaishali has told you. So very quickly, a mental run through. You don't have to ask for all the investigations in all your patients with osteoporosis. But there is absolutely no controversy. When you see an X-ray like this, don't just fix it. I mean, I know in the past, say 2 decades ago, when I used to talk to my ortho friends, they said, what is the big deal? We'll fix the fracture. That's what we are trained for. But it's not just fixing the fracture. A fracture like this begets another fracture in the next 2 years. So we have to think of this as osteoporosis and start the treatment with or without the BMD score. The importance of physical examination has been told. And I think what is very important to be stressed is the loss of height that happens in these grandmothers who have osteoporosis. Evaluation, the bare minimum being CBC, creatinine, calcium, vitamin D, possible parathormone. I would suggest if you're going to start treatment. The importance of bone turnover markers is slowly increasing and again has been stressed by Vaishali, both the resorption and formation markers. Plain X-rays should not be thrown into the dustbin, can give a lot of useful information. The DEXA, where available, TBS, where available, and FRAX should be a part of our routine work. As of today, when you say FRAX India, you're using Indian data from Singapore. But I hope in the next 2 years, the FLS that ISBMR is trying to push with the Indian Orthopedic Association should bring good results and you will have Indian data then. So the FRAX part we have understood, and there is a study from Vellore which says that don't take 20% as a cutoff, but for Indian patients, 10% for non-vertebral fractures and 3% for major hip fractures and 3% for the hip fractures is what is significant. So very quickly, if we get into the main part of my talk, I've kept a couple of cases to keep you all interested. I wish we could be in the same room and I would have asked you questions. But this is something that you would see in most corporate hospitals. 32 years, so I'd say young female, G3, P2, homebound, repeated episodes of backache. Someone has been giving her NSAID, she feels better. But in one of the corporate checkups, she had a BMD of minus 2.6 T-score and femur neck was minus 1.1. And one of my colleagues decided to treat her with zoledronic acid. I repeat that don't make diagnosis, uncommon diagnosis in the young population, especially when the Z scores are not below -2. And all low BMDs is not because of osteoporosis. Probably in our setup, osteomalacia, secondary hyperparathyroidism, vitamin D deficiency will all contribute to low BMD scores. And if you were to actually treat these patients with vitamin D, with or without calcium, and within few weeks, you'll find that the BMD scores really shoot up. See, the general recommendation is to repeat BMD after about 18 to 24 months. I'm not suggesting that you should do it within few weeks or months of vitamin D. But if there is a research protocol, you can think of that. Otherwise, such patients need only calcium and vitamin D. The next is a postmenopausal, about 10 years postmenopausal G2P2, asymptomatic. Again, if you look at this similar figures, spine is T minus 2.6 and the femur it is minus 1.6. I think Vaishali did tell you about the discordance that you may see. And the postmenopausal changes first start in the spine. And then later on, when the type of or the etiology of osteoporosis changes with age, what we call a senile osteoporosis, at that time the femur starts or the cortical bone starts getting affected. So more often than not, these are what you would say garden variety postmenopausal osteoporosis and should be treated, as Sailesh has very rightly said, by non-pharmacological treatment first. Otherwise, the pharmacological treatment doesn't work. I just want to stress that besides calcium, vitamin D, weight-bearing exercise, tobacco is a big no-no. Excessive use of alcohol has to be prohibited. Salt excess is missing. Indians do tend to have a lot of salt, extra salt. So that should be taken care of and eliminating the potential risk factors because most fragility fractures happen after a fall. So if you can prevent falls, you can prevent fragility fractures. The pharmacological therapy, it's, I think, probably the smallest armamentarium of drugs in any disease, maybe near the thyroid drugs, because unlike hypertension or diabetes, where there's a whole gamut of drugs, here you have either the anti-resorptive drugs or the anabolic agents. And an anti-resorptive for practical purposes is bisphosphonates and denosumab. So we're not talking about HRT, we're not talking of SERMs, because this audience hardly would use it. So we'll restrict to bisphosphonates and denosumab as anti-resorptives. Today, we are talking of teriparatide as the only anabolic agent. Probably in the next few months, you'll get romosozumab. Abaloparatide will most probably not come to India for some technical reason. So we have to just take teriparatide and romosozumab as anabolic agents. So very quickly, I mean, just out of interest for you all to see how the osteoblasts and the osteoclasts talk to each other. And the osteocyte, which was supposed to be a dormant osteoblast, has now shown to be a very active part of the whole bone cycle. So osteoblasts produce what is called as the rank ligand, and the osteoclast and the pre-osteoclast, they have got the receptor for nuclear kappa B factor. So the rank is there on the osteoclast and it looks at the ligand to get stimulated. So that's how the pre-osteoclast gets stimulated to be the osteoclast in a normal cycle. When you're using a rank ligand inhibitor like denosumab, which is basically a monoclonal antibody, and it acts as a decoy receptor. So instead of the rank ligand going to the rank, it goes to the decoy receptor, which is again something like OPG or osteoproteogenerin. The other agents which aside we don't use much would either work on the osteoblasts or teriparatide, which we'll discuss a little more in detail, also works through the osteoblasts, and the bisphosphonates work through the osteoclast. There is a very interesting class of agents which are still not there, and I don't know if they'll ever come in the market, and that is what is called as cathepsin K inhibitor, because they work on the enzyme which the osteoclast produces to eat up the bone. So that's something because of the vascular side effects, increased risk of stroke, that cathepsin K inhibitors or odenocative, etc., will never come into the market. And just for your information, Dr. Sailesh Pitle was the #1 PI when we did the study with odenocative, and he, I think, deserves a lot of kudos for putting in so many patients on this treatment. So we are, I think, as a group, are familiar with the effects of these agents. But very quickly, let's look at the side effects, because time and again, the treatment of osteoporosis goes into disrepute. People stop using it, not because it's not effective, but people have bad publicity. Hypocalcemia, GI symptoms, you can get severe aches and pains with a bisphosphonate. You had certain bad publicity because of the atypical fractures or osteonecrosis of jaw, which are actually a problem, but I'll show you how serious a problem it is. We can't use it beyond stage 3 CKD, and there has been some fear of atrial fibrillation with zoledronic acid. As I said, raloxifene is hardly ever used in practice, and it's contraindicated when the patient has a history of venous thromboembolism, some history of stroke. Teriparatide is a reasonably safe molecule, but can cause pain at the site. It can cause girdle-like pains. It can cause transient hypercalcemia with, use of this molecule. But, if you cut down on the calcium supplement and the vitamin supplement in these patients, most patients would correct that hypercalcemia. I'm assuming that before prescribing teriparatide, you have checked the calcium and PTH, and we are not dealing with primary hyperparathyroidism. This fear about osteosarcoma is now done and dusted. There is no incidence of, no increased incidence of osteosarcoma in patients treated with teriparatide. And as a matter of fact, the US FDA has also removed that black box warning. And if necessary, in certain situations, you can use teriparatide for longer than 24 or 30 months. We are worried about these so-called atypical fractures. Atypical because the typical fractures that you see in osteoporosis, the vertebral compression, the Colles fracture, the intertrochanteric femur neck fractures, is not what we are talking about. These are subtrochanteric fractures and should not be a part of osteoporosis. And that's why we are worried about them. And the other thing which could be serious, especially, Vaishali did tell you about dental hygiene, but more often than not, these are patients who are immune compromised, malignancy, very large doses of steroids, and the regular garden variety patient of osteoporosis has this very rare complication. So put it in perspective, this was a Canadian study that if you were to look at fatal motor vehicle accidents, about 8.4 per 100,000 person year, murder is about 1.8 per 100,000 person year contributing to mortality. Osteonecrosis jaw was less than 1 per 100,000 patient years. And atypical fractures in the short duration of bisphosphonates was about 2 per 100,000. And then when you're using longer duration, 8 to 10 years, it reached about 100 per 100,000. So with a longer duration, the risk of atypical fractures does increase. But if you see here that for every one atypical fracture, you are preventing about 100 hip fractures. So this is a price which you should take into consideration. Keep in mind that if you keep the duration of bisphosphonate therapy to, say, 2 to 5 to 7 years. And there are sort of markers which tell you that this patient can likely develop atypical fracture. There are studies from Australia. Peter Ebling has shown that Asians are actually more prone to atypical fractures as compared to the Caucasians. The important thing is the patient should take the therapy that you have prescribed. It should, unlike diabetes or hypertension, cholesterol, where we never talk of duration of therapy. For osteoporosis, it's always a finite period. We've looked at the possible side effects with antidissociative agents. We are, not sure how useful teriparatide is after 24 months. So it's always a finite period. Romosozumab also studies have looked at only 12 months of therapy, once a month for 12 months. In select cases, patients on bisphosphonates, after using the appropriate drug for appropriate time, and if you find that the patient's T-scores have improved and have, the risk of refracture has gone down, the bone markers are suppressed, patients can be given a drug holiday. But there's no question of drug holiday with a teriparatide or with a monoclonal antibody like denosumab, which has a very short period of action. There is no memory effect. The memory effect is only with bisphosphonates. Yeah, so as I mentioned, very selected patients, you can use bisphosphonate holiday. So let's progress with our cases. As you can see, the severity is increasing with each new case that I'm putting up here. Most of these have actually been made up just for illustration, but the last case is actually my case, one of my friends, and I'll tell you about her later on. So this is again, a routine examination. You find that the patient has a compression fracture L2, and the spine t-values are minus 2.3. And the femur neck is minus 1.6. So we could argue about the BMD scores, but there is no argument about compression fracture of the vertebrae, especially if it's a lower thoracic or a lumbar vertebral compression. This is most likely osteoporosis. The ortho colleagues would know that the high upper thoracic vertebrae, you need to look for secondary causes, and malignancy is something you must always think about in the elderly people. As I mentioned, the best treatment will work only if the patient takes it. And the interesting part is with the oral anti-osteoporotic therapies, less than 50% of the patients are actually taking treatment at the end of 1 year. So if the adherence is going to be about 50%, the risk of fracture or the reduction of fractures is definitely not going to be as expected. Yeah, so this is the interesting part. 50% stop at the end of 1 year. 13% never start the prescription that was given to them in osteoporosis clinic. And that is why a longer acting parenteral drug is something that we like to give a choice to our patients. The other fear that comes up is, should we be starting anti-resorptives immediately after a fracture? One thing we know is that during fracture healing, there is going to be a lot of remodeling. And if you were to use the anti-resorptive, would you be interfering with fracture healing? And the short but correct answer is that no. You can use anti-resorptives within 4 to 5 days of fixing the fracture. It used to be 2 weeks, but now it has come down to a period when you are about to discharge the patient. You can give either the injectable denosumab or the injectable zoledronic acid. Unless, the patient just refuses to take the injection, because sometimes patients say, oh, this is a very powerful, long acting. I would like to take something that works for once a week or once a month. The sad part is that, some patients have had fractures, but were ignored, whether it was out of ignorance or whether the patient didn't take the doctor's advice. The fact is that one fracture gave us a warning. She didn't take action. She came back with more than one fracture. So this is severe osteoporosis and probably calls for really drastic measures. You can see the T-scores and the femur neck scores also have become very scary. And there is absolutely no doubt that this patient should receive teriparatide as a first-line drug. Now, I didn't get into this discussion whether teriparatide should be the first-line therapy for every patient of osteoporosis. Some people would say, why not? Because that is the best drug to increase the bone mass, and then go in for anti-resorptives to prevent the further loss of bone mass. But the problem is when you tell someone to take it daily for 2 years, 8 out of 10 patients in routine practice would say no. Unless, they've had multiple fractures or there is some relative who's there in the family to tell them, they would listen to you and then within few weeks stop taking. So again, I repeat, any treatment is as good as the patient's taking it for the required period. So if you can't give the best treatment, go for the second best treatment so that the patient would at least benefit, if not 100%, then 80%. As of now, it is daily subcutaneous injection, but about a decade ago, and I think in India also, you will be getting once a week teriparatide option. So that's something you can look forward to. As of now, like I said, 2 years. Question that comes up in the exam is, if you were allowed to give it for 3 years or 4 years, would you do it? And the reason we don't really recommend it for a longer period is, teriparatide works initially by increasing the bone formation markers, which is then followed after a few weeks by the bone resorption markers. So this window that comes up in between is where the actual bone formation takes place. So it's a matter of few weeks to few months that there is the resorption markers are lagging the formation marker. Towards the end of 1 year, if those who are following up with bone markers, you will see that the P1NP, which had gone from say 30, 40 to 120, 150, then starts falling down to 80, 70. So please be very careful, because your patients are going to get very upset when they see their P1 peak going down. The other thing that really disturbs them is when you ask for a BMD on a patient who's taking teriparatide, and you will find that the spine scores may improve, but the hip scores may actually worsen. And the reason is that, with teriparatide, it's not only that the mass increases, but the area also increases. So mass upon area may not increase or may actually decrease. So you have to tell your patient that this is a part of the mechanism of action, and not get worried that the BMD values have gone down. So this gives you an idea. That's the mass upon the area. Here the mass has increased, but even the area has increased. So the total score may still remain the same. Can we use denosumab with teriparatide when we are worried about very severe osteoporosis? Good old days, they thought about combining alendronate with teriparatide, and it was shown that the combination did worse than the teriparatide alone. So that went out of use. And now in the last few years, there have been one or two very good studies, small studies, but done very well, showing you that the combination may be a good idea from the beginning. So this is the data study. Needed only 100 patients, divided into 3 equal groups. The first one received teriparatide. That's teriparatide. The second, so that's denosumab, teriparatide, and a combination with denosumab and teriparatide. So at the lumbar spine, you can see a very good increase in the BMD. At the femoral neck, also with the combination and the use of denosumab, good increase in BMD. Please note, at the femoral neck with teriparatide, the response was less. The same thing at the hip, teriparatide was the least, denosumab and the combination. And at the distal radius, again, teriparatide was the least, but denosumab and combination did better. So this is one of the important messages, because when we have a discussion on my last case, should we be using this for hip fractures or not? After 2 years, these patients underwent a switch. The patients who had received teriparatide switched to denosumab. Patients who received denosumab switched to teriparatide. And the patients who were on combination continued with denosumab, because teriparatide is given only for 2 years. And the outcomes, so this is what was there at the end of 2 years. The outcome was the teriparatide to denosumab did exceedingly well. The combination to denosumab did exceedingly well. The denosumab to teriparatide. See, that is where you have to learn that when you have gone from an antiresorptive to teriparatide, it takes some time. I'm not saying it doesn't happen, but it takes some time for the action to take place. So that's the important carry-home message, that if you have the thought that you're going to use an anabolic agent, please use it first and then use the antiresorptive. Because if you use the antiresorptive first, the anabolic agent works after some time. The same thing is seen on the femoral neck, at the hip, and with the radius, actually, you can see that there's hardly any improvement when you add teriparatide to denosumab. So again, when you have severe osteoporosis, think of using denosumab and teriparatide at the beginning. As I mentioned, this is one of my friends, and I had specifically told her not to fall on trip. And she called me up one fine day saying that she tripped over a wire in the office, landed in the hospital with a right intertrochanteric femur fracture. Mother had a history of similar hip fracture, and scores were pretty bad. So as I was talking to you about what is a good therapy for post-hip fracture osteoporosis, and probably teriparatide, alendronate come in this region. Denosumab comes as a clear winner with zoledronic acid somewhere down here. The difference is that whether you're using alendronate or zoledronic acid, after about 3 to 4 years, the effect tends to plateau. Whereas with denosumab, the effect goes on increasing till about 10 years of therapy. So there, probably denosumab has a certain advantage. And when you see romosozumab in practice, 1 year of romosozumab followed by denosumab would be a clear-cut winner. For those who are interested, I did pick up 3 or 4 good recent reviews. Advances in Therapy 2022. They have looked at the advantages of using denosumab over a 10-year period and very favorable increases in bone density. What we have been worried about and we've been reading recently is that if denosumab is stopped and not followed up with some antiresorptives, the fracture risk goes up. It actually goes up nearly to what it was before they started treatment, or even as some studies show that it goes more than what it was earlier. Another study from the European Journal of Endocrinology 2021 has recommended using zoledronic acid specifically or alendronate after denosumab treatment to reduce the vertebral fracture incidence. Data from Freedom, and you'll see these guys, Steve Cummings, Michael McClung, Serge Ferrari, these are the ones, people who have been working a lot on this post-treatment fractures. And here, again, from the post-analysis of Freedom and Freedom Extension, that the fracture risk in patients who are not treated, these are non-vertebral fractures and these are vertebral fractures, when they go off treatment, the risk increases, but it goes to about same that you see if the patient had received placebo and had not received treatment. So the point is denosumab effect wanes off fast and you need to follow it up with an antiresorptive treatment. This article, or it's a meta-analysis, actually discusses this rebound phenomena in a great detail. And what is interesting, I've put 3 pointers out here, that if this patient has received denosumab for a short period, 2 to 3 years, then a single injection of zoledronic acid 6 months after the last injection of denosumab actually preserved the bone density gains for up to 80% patients. And you need to not give it every year, but you can give it every 2 or 3 years based on the NTX or CTX. The problem comes up that if the patient has been on a longer duration, that means 4 to 5 years of denosumab, then a single zoledronic acid or the use of alendronate may not prevent this bone loss, and you may need to give more than 1 injection at shorter intervals, again by following up the NTX or CTX. And this is the same thing, short duration of denosumab, go to zoledronic acid or bisphosphonates. Longer duration, you're going to need more. So this is something which I myself read and heard recently. So I thought this should be, because we keep telling give treatment, and give it for a finite period. But what happens after you're given is something which, left to a lot of guesswork. So this same article does tell us that when you're looking at withdrawal of denosumab, prevention of bone loss is very important. Patient needs treatment. Just 3, 4, or 5 years of treatment is not enough. There are very limited data available, as I showed you, just 2 or 3 studies. But you may need to follow this 1 injection with bone turnover markers, as I mentioned. If it's a short duration of denosumab, you won't need much treatment. You can go on to once in 2 years or once in 3 years. But if it's a longer duration, they're going to need more observation. Bmd testing should be done annually in these patients, and the Bmd may be able to tell you that something is wrong at an earlier stage. That's it. And X-ray and VFA, where available, are good tools. Spine X-rays are easy to do, even if BMD is not available. And the duration of subsequent bisphosphonate therapy is to last at least 1 to 2 years, but this will continue for a longer period. The last part of my study as a talk is on FLS. I think I've come to the end of my time, but I want to stress that a fracture begets another fracture. And for those who are interested, if you go to the APCO website, a beautiful collection of about 200 slides are available for each of you for free. And it's a lot of useful information in this. So this tells you all the various fractures that can happen in the next 2 years. And I've made it simple out here that one wrist fracture begets another wrist fracture 3.3 times. Vertebral fracture 4.4 times, but also increases the risk of hip fracture. And a hip fracture leads to a vertebral fracture 2.5 times or hip fracture 2.3 times. So stressing on the point that one fracture is a warning. And if we cannot prevent the first fracture, at least we should work towards preventing second fracture. The mortality after osteoporotic fracture, especially after hip fracture, remains high even in the best of centers. And the last 2 or 3 slides, again stressing on the fact that drugs don't work in patients who don't take them. There is a treatment failure that may happen in the best of patients, but keep in mind the compliance has to be checked up. The bone turnover markers may give you an idea if they're taking the therapy properly or not. Rule out secondary causes. And in spite of the best of intentions of the treating doctor, you may have treatment failure that is more than one osteoporotic fracture 1 year after treatment. And then you need to go one step up. So from alendronate to parenteral, denosumab or zoledronic acid, or in rare situations, especially when you have the atypical fractures, then you need to use teriparatide. The ACE 2020 guidelines, the ISBMR 21 guidelines, I think even Vaishali told you very clearly the set of patients who need treatment. So the important point is osteoporosis is a silent disease, but a very serious disease at personal and community level. We are all living longer, so we are all prone to osteoporosis. Easy to diagnose if you think about it. Prevention is much better than trying to treat it. Multiple options are available. Choose, keeping in mind patient's choice, your information, and the compliance factor. And fracture liaison service, which I hope we'll talk about it on some other day, is very, very important for you. I'm going to stop sharing at this stage, and I'll be happy to take questions.
Thank you, Manoj, for this beautiful presentation and taking us through the nitty-gritties of what therapy after what and which would work better. So,
Can I ask something?
Yes, sir.
Yes.
Yeah. Hi. On one side, we say that BMD does not predict the fracture, incidence of fracture, or that is not the only factor. While most of the drugs, when we are analyzing the effects of those drugs, almost all papers mention only BMD as an endpoint and not the fractures.
No. So, Dr. Agashe, the first part is that BMD is the best available today.
Correct.
The second thing is we used to look, the old studies talked about increase in BMD, but all the new studies talk about fracture risk reduction in addition to the BMD going up.
Okay.
So we are very clear that just increasing the BMD with strontium or fluoride is not what we are looking at.
Right. Okay. Thank you.
Manoj, I have a question. That we often stress PTH should be used for only 1 to 2 years. But are there no study at all to see the safety of PTH given for, say, long term?
No. So, Dr. Patwardhan, the safety part has been set aside now. We are not worried about it. The question that is it worth giving more than 30 months? Okay. See, GIOP was allowed for 30 months. Other practice was 24 months. And what I mentioned, that the teriparatide works on the window of opportunity where the formation far exceeds resorption. Afterwards, the bone biology is such that the formation and resorption are linked. So whether giving 3, 4, 5 years is going to make much difference, we don't have an answer.
I have got few patients who have got primary hypoparathyroidism.
Oh, that's a different ballgame.
I'm just asking you, can you give them PTH lifelong?
You can. I have used it in 2 patients. Actually, the recommendation is for NAT-para, which is the total PTH, but what we have is teriparatide. Let me tell you, Dr. Patwardhan, we have Sanjay Badada from PGI has looked at using 60 micrograms of this teriparatide once a week. Japanese have accepted this, but they have it's 1 to 36. There's a little modification in the PTH molecule, and the 1 to 84, the full molecule is also been studied in once a week dosage.
Okay.
Sir, there is a question.
There is a question like how long we can give alendronate?
I think that answer is very clear. First for 5 years, then review the BMD and the bone markers. If the patient is still at high risk, scores are still below -2.5, then you can go up to
How
10
long
years.
we can give
10
an
years.
donate?
Yeah, total 10 years.
I have a question. So recently, me and Dr. Agashe were involved with another meeting, something similar. So what I was understanding before that meeting was that when patient comes to me with a neck femur fracture, which I have fixed, I should be giving teriparatide, which also helps in fracture healing. But in that meeting, I understood that actually teriparatide has very minimal role in hip fractures. It has more role in spine fractures.
Absolutely. So, Neeraj, I think if we had this discussion about, say, 7-8 years ago, 10 years ago, I would have told you that teriparatide doesn't have a role in hip fractures. But now the thing is, it does have some role. It's not as good as denosumab, number one. And as I talked to you about data switch, should we be using the combination right from the beginning? That is something which you should discuss with your patients.
I feel that, see, my personal, not scientific, but I don't know whether it is scientific or not. So patient has to live with osteoporosis for 20-25 years. And patients who are not tolerating the alendronates and the zoledronates, we have only 12 years of treatment left for them, means 10 years of denosumab, 2 years of teriparatide. So I would not want to finish that 12 years in 10 years, is what my take is. Am I right in this thinking or am I wrong?
You're absolutely right. See, unlike any other non-communicable disease, we never talk of duration of treatment. So the thing is, sometimes in the past, my ortho friends used to ask me, at 40, I will start treatment when there is osteopenia. Why should I wait for osteoporosis? When I know that it is going from bad to worse, why not start? So the reason is we don't have today treatment which I can say that, listen, you live till 90, I look after you. So whatever 10, 12, 15 years we'll have of treatment, the only hope is, especially with the zoledronic acid, we keep talking of once a year. But really, if you follow bone markers, it could be once in 2 years, once in 3 years also. We don't have a clear-cut answer because this thing gets deposited in the osteoclast and stays there for years together. So we need to, do the markers more often than just follow it empirically once in a year. In Paget's disease, for example, one injection of zoledronic acid may keep them normal for years together.
And the zoledronic acid dosage is different for osteoporosis and different for cancer, something which I don't understand. Metastasis, that is. Same as with denosumab.
Yeah, no. So denosumab is 60 to 120. So it is double the dose.
Right.
But for what we use is 5 milligrams and the oncologists use 4 milligrams. But they use it much more often than what we use, once in 3 months, once in a month, once in 2 weeks. So probably that mental thing is that at 4 milligram is less than 5 milligram, but it's the same injection.
And the zoledronic acid will cause fever, will cause a lot of body ache. So what is the longest you have seen that there is problem persists in the patient? Means what should we tell the patient? Be prepared for 3 days, 4 days or 1 week with body ache and fever?
48 hours is generally what we would tell our patients to take only paracetamol. I had my colleagues at Hinduja used to use steroids. Fortunately, that has been stopped now after arguing and fighting with them. Paracetamol works in most patients. So if it has gone beyond 48 hours, you need to look for some other reason.
And can it be given in patients with low GFR?
Yeah, so I said end-stage renal disease is out up to stage 3 CKD. That means up to 30 ml, you can use any bisphosphonate. Below that, I think only denosumab is the safe option. I wish we could use teriparatide as selected patients, but by the time they reach stage 5 or they've gone into dialysis, their PTH levels have gone 200, 500, 800.
So Manoj, sir, I have a question. Suppose the patients have glucocorticoid-induced osteoporosis, it is recommended that we start teriparatide, right? Yeah. But most of these patients are going to be on steroids off and on. So after 2 years, you shift them to denosumab or you want to add zoledronate?
Yeah, Vaishali, I think teriparatide followed by antiresorptive is the option for these patients who are going to be on long term.
So can we actually use denosumab in these patients instead of teriparatide?
Only denosumab you can use that. There is evidence to that.
So it was a very nice talk.
Thank you, Vishali. I think we should go to the next section now. The other, I can see a lot of them waiting eagerly and abusing me.
I think I would like to thank all the speakers, Dr. Vaishali Madam, Dr. Pitale Sir, Dr. Chadha Sir. Also, thank you, Dr. Mohan Magdum Sir and Dr. Bijlani. It's over to Dr. Aasim and Dr. Chandni.
Thank you, sir. So we'll move on to our next session, which is basically a case discussion, and chairpersons will be Dr. Agashe and Dr. Vivek Dwivedi. Dr. Vikas Agashe is a consultant orthopedic surgeon in PD Hinduja, and Dr. Agashe's maternity and surgical nursing home. He has given a Golden Jubilee Oration Award by the Indian Orthopaedic Association in 2019. He is the chairman of Trauma Committee, advisor of Infection Committee of IOA, and he is an honorary president of Bombay Orthopedic Society from 2011 to 12. He is a faculty at international and national conferences, and he has various publications in these journals. His special interests are trauma, non-unions, osteoarticular infections, osteoporosis. Sir is actually an authority in the infection of orthopedic and articular infections, and a very humble teacher. And our other chairperson is Dr. Vivek Dwivedi, who's a senior consultant orthopedic surgeon in Mira Bhayender. Sir has been instrumental in forming the Mira Bhayender Orthopedic Association. He's a trustee of Bhayender Medical Association and past president of IMA Mira Bhayender and Bhayender Medical Association. So I hand over the session to the chairpersons now.
Agashe sir, you are muted. Thank you very much. I'm sure all of you are eagerly waiting for this panel discussion. So may I request Dr. Ferwani, Dr. Pankaj Ferwani to initiate this panel discussion.
So, are my slides visible?
No, I don't think so.
Yeah, Pankaj, meanwhile, let me introduce the panelists. Dr. Pankaj Ferwani is a consultant endocrinologist who actually was a part of Maha Endocrine Society, but has now migrated to Surat. We are also privileged to have Dr. Kanchan Keval Ramani, who is a senior endocrinologist practicing in city of Thane, as well as in Mulund. Dr. Aditya Kashikar, who is attached to Lilavati Hospital as well as Wukhad Hospital and working in North Bombay. And Dr. Agnivesh Tikku, who is consultant orthopedician and spine surgeon at Apollo Hospitals, Navi Mumbai. Over to you, Pankaj. Your slides are visible now.
Thank you, Ameya sir, and I would like to thank Maharashtra Endocrine Society for giving me this opportunity to participate on the day of World Osteoporosis Day. Most of the discussion has already been done, and this is just kind of a revision of the previous discussion. So I will be discussing cases and followed by the questions relevant to the cases and some take-home messages. So slides are not moving.
You can reshare, Dr. Pankaj. Stop and again restart.
now slides are movable.
Yeah, you can start sharing the screen or making it full screen. Please make it full screen.
Okay. So now slides are movable, right?
Yes.
Yes.
So this is a case first. 65 years old lady. She is a menopausal, attained at the age of 50 years, diabetic since 15 years, hypertensive since 10 years, and having primary hypothyroidism since last 8 years. She was referred to endocrinology OPD for glycemic control and levothyroxine dose adjustment. She had undergone health checkup package, and just for sugar control, she was sent to endocrine OPD. So there was no significant family history, but because she came to OPD and she was aged lady, and I just asked what are the other things she may be suffering from apart from her glycemic control. So she gave the complaint of low backache with occasional tingling sensation in right lower limb since last 4 months. And she had shown the paper where already neurology consultation was done and calcium, vitamin D, pregabalin, and B12 was prescribed, and she was advised to follow up after a month. So she was on glimepiride, metformin for the glycemic control, telmisartan 40 OD for her hypertension, and LT4 of 50 micrograms per day. Her sugars were not very well controlled, A1C of around 8, fasting of 140, ppbs of 188, and TSH was 4.7. So just I went on inquiring further because as an endocrinologist, we always reflexively think whether there is underlying osteoporosis. So there was 1 cup 2 to 3 days in a week milk intake, and sunlight exposure was suboptimal. Examination, nothing significant except for tenderness in the lumbar area. And she had already undergone lab investigations, so everything was normal except for vitamin D deficiency, and PTH was on higher side, little bit higher side. So this was the X-ray which she had shown, and this was clearly suggestive of some fracture in lumbar vertebra. And this is a Genant classification which already has been discussed in the previous talks, depending upon the compression grades 1, 2, and 3. So she came for health checkup and she was sent for glycemic control, but this was the new thing added to her clinical evaluation. So slides are again not moving.
Dr. Pankaj, just click on the center of the screen and then try moving the slides. Yeah.
Okay. So with this case scenario, I would like to ask questions to our panelists. This is the question to Dr. Aditya, who is an orthopedic surgeon. What is the surgical management of vertebral fracture? So
basically, in this particular case, since patient has got occasional low back pain and mild tingling in the legs, but as such, there is no history of claudication along with that. And overall, the X-ray picture looks old fracture. So taken into consideration her age and other blood parameters, I think we have to just, in this particular case as such, we can just treat this condition non-surgically. If we talk about the surgical options, obviously surgery is advisable in 2-3 scenarios where if patient is on patient diagnosed to have acute vertebral compression fracture and was given enough trial of conservative treatment for usually for 4 to 6 weeks period. And after that also, if they just keep on complaining about instability fracture, that while turning in bed, they are finding it difficult, or while getting up, because usually on conservative treatment like bed rest, as days pass, they do feel better, their mobility improves. But in certain scenarios where fracture healing takes longer time, it's delayed healing, this instability creeps in, and at that time, they start complaining of severe excruciating pain. So instability is one of the main indications of surgery in osteoporotic compression fractures, along with, if at all, with or without any neural compression causing any deficit. So for me, surgical management comes in picture only if there is any instability or instability with or without neural compression causing any neurological issues. I think Dr. Agnivesh can highlight further any points.
Yeah, thank you, Aditya. Dr. Pankaj, can we go back to that X-ray?
Yes.
Yeah, so Dr. Aditya has covered most of the things, but a lot of information is given by this one X-ray. This fracture is healed, which itself proves that it is something which is treatable and reversible. Like it rules out a pathological fracture. A pathological fracture would not heal. We can see this bridging osteophyte developing over there. Now, the question comes of surgical treatment. The classification which is there is something which most of the clinicians do not follow in regular practice, because it does not matter whether it is grade 3 or 2. It matters whether the patient is healed, walking, or whether he is bedbound or has a neurological deficit. Now, the role of surgery comes in those typical situations where there is a neurological deficit or patient fails to resolve to a conservative treatment. But 90% of these fractures, they do heal with rest and medical management, and very rarely you need intervention for them. So the first attempt in these is to sort of get them, give them rest, give them medications, do a basic workup, and then try to mobilize them as soon as you can, from at least from bed to chair. And then you sort of build it on that.
Okay, thank you, sir. So this was very nice discussion about the surgical management of the vertebral fracture. So can vertebral fracture be managed conservatively? This has also been answered by the panel discussion. To Dr. Kanchan, I would like to ask, relevant to this case, at what age screening for osteoporosis should be considered, and how will you approach this case?
Basically, osteoporosis we should start screening for osteoporosis in postmenopausal women above the age of 60 years, and in men 65 years of old or older, irrespective of the clinical risk factors. And if we are looking at a younger age group, say less than 60 years in women or between 50 to 64 years in men, then we should consider screening if there are relevant clinical risk factors. But as far as this patient is concerned, irrespective of her clinical profile risk factors, she should be start screening at the age of 60. And how would I approach this case? Basically, if you go by the history, the patient has a lot of risk factors for osteoporosis. Right from her age, again, diabetes is a risk factor for osteoporosis itself. Even when you look at her nutritional history, her calcium intake, her vitamin D exposure is very poor. Even if you dig more into her history, I'm sure her lifestyle, there would be not much of exercise or resistance training in her, which would have led to a lower BMI. Even if you see looking at whatever examination findings she has, her BMI is on the lower side. So again, these are all risk factors for osteoporosis. Even in her management, like when you look at her investigations, she is vitamin D deficient with low calcium on the lower side, hemoglobin is on the lower side, her HbA1c is 8. So all these are risk factors for low bone mass or low bone density. So we'll start from there. Secondly, coming to examination, we need to see whether she's got any history of decrease in the height, as it was rightly discussed in the earlier talks as well, or whether there's any evidence of kyphosis or scoliosis, which, gives clues to the presence of osteoporosis irrespective of the fracture. Of course, she had tenderness in the lumbar area, so which could mean that though X-ray showed an old fracture, but that could also give us a clue whether there was a new onset or an acute onset of a new fracture which was leading to her pain and tenderness. Being a diabetic, we should examine her for peripheral neuropathy, because that is one of the major risk factors for falls in these patients. And since the X-ray shows that it's an old fracture, so I'm sure she would have had some imbalance of gait or some falls which would have led to this fracture. So all this comes from the examination part of it. Coming to the management, the most important is vitamin D and calcium, which needs to be corrected. We aim to keep a vitamin D above 20 and preferably between 30 to 40. So we would definitely start her on vitamin D supplements orally, where we've seen that oral absorption is much better. And we need to start her giving 60,000 international units once a week for at least 8 weeks, followed by a maintenance dose of once a month for at least a year, because we need to keep them after correcting the deficiency, they should be on a maintenance therapy of at least 1,000 to 2,000 international units per day. Again, calcium is again another important thing which needs to be supplemented, because going by her history, she was not on any calcium supplements. And even from her diet, she was hardly getting 120 to 130 milligrams of calcium, because she was hardly consuming milk twice a week. So calcium should be supplemented. Peripheral neuropathy, if she has, fall prevention is a very, very important thing which she needs to be counseled about. So right from her footwear, to the use of railings, to the use of, keeping the environment well lit, like prevent darkness in the rooms. Even the carpets, like it's very common where we see old people just stripping off the carpets which are left, on the floor. Again, wet floors, especially in India, we are very concerned about cleanliness, and we keep on monitoring how the women, the maids are working. So they have a tendency of, some women going around the maids, and even they are sweeping the floors, they are wet. So this is again a very common incidence where they tend to slip. So all this is very important, when you counsel patients for osteoporosis. So prevention is very important. So the prevention of all strategies have to be reinforced. And coming to the treatment part, definitely I would like to start her on treatment for osteoporosis, because a fracture, irrespective of the BMD, we don't have a BMD on her, but a presence of fracture is good enough and evidence for the treatment of osteoporosis, irrespective of her T-score. So ideally, for vertebral fracture, teriparatide would be my first choice. But again, we need to counsel the patient regarding the daily use of injections and even the affordability. So if she can afford, I would definitely want her to put on teriparatide, which she needs to take at least for 18 to 24 months, followed by a bisphosphonate. However, if she's not, cost is an issue, then even the next best option would be to give her yearly zoledronate. And as far as her follow-ups are concerned, we would definitely want to see her the first time after 3 months to see if she's adhering to therapy and she's following all the strategies for fall prevention. Next, we can follow her up maybe 3 to 6 monthly in the next 2 to 3 visits, and thereafter annually should be. And as far as monitoring is concerned, after the first DEXA, the next DEXA, I would like to see at least after 1 to 3 years to see the change in the BMD and then decide about the further line of management.
So thank you, Dr. Kanchan, for very nice and scientific elaboration. So this was the thing which Madam I already discussed. I advised her to undergo BMD DEXA scan, but she refused. And so treatment was given in the form of vitamin D and calcium, as well as I convinced them to at least take zoledronate. But after discussing the option of teriparatide, as Madam has already discussed, so she had received around 10 to 15 days back first dose of zoledronate acid, and she's asked to follow up with BMD DEXA scan report after a year. So take home message from this case is screening for osteoporosis should be considered in women more than or equal to 60 years and men more than or equal to 65 years of age, regardless of clinical risk factors like low body weight or prior history of fracture, or rheumatoid arthritis or steroids. BMD DEXA should be done for screening. Minimum X-ray lumbar spine should be done if BMD DEXA machine is not available, as already been discussed in earlier. And high threshold of T-score, like less than or equal to -2, should be considered in diabetics for osteoporosis treatment, because diabetes, even though T-score it looks normal, but bone architecture is disturbed, so the threshold should be high. And drug or drug dose like levothyroxine over replacement should also be looked into, because as already been discussed in previous talks that it can cause resorption of the bone and again worsen the osteoporosis.
Correct. So I just wanted to add one point here, like you always tend to overtreat hypothyroidism. They always want to keep the TSH as low as normal, but that is really not required. A TSH of between 3 to 4 is good enough. So in the process of overcorrecting hypothyroidism, you tend to make the patients more prone to being thyrotoxic, and that has a negative effect on the bone, where it causes increase in the bone resorption. So titration of those is very important. And as you rightly said, which I missed the point, was about the T-score. In diabetics, we have to consider a T-score of -2 for the treatment of osteoporosis and not -2.5, because unlike in type 1 diabetics where they have a low BMD because of insulin deficiency, though in type 2 diabetics the BMD may be good, but the bone architecture is really poor. and therefore you need to consider a lower threshold for treatment in patients with type 2 diabetes.
Yeah. So thank you. So case number 2. This is a 68 years old lady, diabetic since 10 years, hypertensive since 5 years. She attained menopause at the age of 55 years. She is on glimepiride and metformin as well as pioglitazone for her glycemic control. She presented to hospital with pain in left hip region with following trivial trauma and found to have fracture femur neck, and that was managed surgically. And for further further expertise management, endocrinology consultation was sought. That's kind of fracture liaison service which I had learned in Hinduja Hospital when I was resident. So I am trying to follow the same thing in the Surat Hospital also. So again, same history was asked related to fracture. There was no significant family history, but she had a left forearm fracture around 8 months ago following fall from vehicle. And at that time, she was managed with cast and was given calcium and vitamin D supplement. So, but she was not put on any anti-osteoporotic drug. And examination-wise, there was pallor. BMI was on lower side. Otherwise, systemic examination was normal. Hemoglobin was on lower side, and vitamin D was in the range of insufficiency. PTH was borderline high. Otherwise, creatinine and alpha was normal. So, pertaining to this case, I would like to ask our orthopedic Dr. Agnivesh. So how we usually, how do you manage a Colles fracture? Is it like only always conservative, or sometimes even surgery is also required?
Dr. Pankaj, Colles by definition is an extra-articular fracture. So if it is minimally displaced, there is not much of dorsal angulation. There is something we call as ulnar variance also. Normally, if you see an X-ray, the distal end of the radius is slightly projected more distal than the end of ulna. Now, if ulna goes ahead of radius because the fracture has impacted and the radius has been punched back, so that can create problem later on because of the malalignment of the distal radioulnar joint. So basically, most of the Colles fracture, if they are minimally displaced, the angulation is not more than 10 degrees dorsally, they tend to go for conservative treatment and they heal very well. The surgery is reserved for intra-articular displaced fractures, or if there is ulnar variance, or there is anything else which is complicating the fracture where you need to do a surgical treatment.
Thank you very much, sir. So I would like to ask Dr. Kanchan. So what is the effect of available OADs or anti-diabetic treatment on bone per se?
So basically, as we all know, as we discussed, type 2 diabetes is a risk factor for osteoporosis. And in addition to that, it's even the management, there are a lot of studies which have looked at the bone effects of the various OHAs. So from bone perspective, I would say metformin is bone protective because it inhibits osteoclastogenesis and it also inhibits the destruction of the osteocytes. So it has an anabolic effect on the bone. Next is the sulfonylureas have a neutral effect. Basically, though it does not have any much effect on the bone, but because of if fall is a criteria for fractures, and definitely because of its propensity to cause hypoglycemia, sulfonylureas can indirectly increase harmful effects on the bone in the form of falls due to hypoglycemia leading to fractures. Coming to GLP-1 analogs, they have again a neutral effect or rather a positive effect. There are various studies which have shown that ingestion of food leading to stimulation of GLP-1 leads to a decrease in the bone resorption. So in that case, they have an anabolic effect on the bone. So they are positive. So when we have to choose drugs, metformin, GLP-1, and your DPP-4 inhibitors have a positive effect. Coming to the other drugs like liposomes, they are the ones among all the anti-diabetics which are proven to be having the maximum ill effects on the bones. Now, basically, it's all through the mechanism of the PPR gamma receptor where they act, and it is a pro-adipogenic drug. So what it does is it inhibits the conversion of stromal cells to osteoblasts. It also stimulates osteoclastogenesis. So when you're deciding about choosing a drug therapy in patient with diabetes, especially who's at high risk for osteoporosis, pioglitazone should be avoided, definitely, because these are the drugs which have maximum problems as far as bones loss is concerned. And they also inhibit osteoclastogenesis. And the third drugs are the the SGLT2 inhibitors. Now, there are various studies which have shown that dapagliflozin, empagliflozin has neutral effect, but CANA was found to be associated with a number of fractures. But though this drug has gained wide popularity as far as the cardiovascular benefits and the renal benefit is concerned, but its effects on the bones, it was found was basically secondary to the hypotensive effect. And also there was weight loss because of glycosuria leading to balance issues. Also there is urinary loss of calcium, which leads to secondary increased parathyroid hormone secretion. So these were the indirect effects of SGLT2 inhibitors on the bones. So again, from bone perspective, metformin, GLP-1 and DPP-4 would be preferable over sulfonylureas, pioglitazone or your SGLT2 inhibitors.
So thank you, ma'am. So why PTH?
First, not to forget insulin, because insulin is an anabolic hormone. So as we see in type 1 diabetic patients, deficiency of insulin reduces the peak bone mass. So definitely insulin has a positive effect. But in patients with type 2 diabetes, again, the cause of ill effects of fractures would be hypoglycemia. But otherwise, insulin has an anabolic effect.
Thank you, ma'am. So why PTH is high in this patient and what is the most common cause of high PTH in clinical practice?
In clinical practice, the most common cause of high PTH is vitamin D deficiency. So that's what is called as secondary hyperparathyroidism. And so that is the most common cause. So we should always, before investigating the causes of PTH race, we should first correct the vitamin D, reevaluate the PTH, and then only look for other causes. But vitamin D deficiency is the most common cause for increased PTH in this patient.
Thank you, ma'am. So as this patient had a history of Colles fracture, so can osteoporotic drugs be prescribed to the patient based, will you consider anti-osteoporotic drugs in patient with this Colles fracture without osteoporosis based on Bmd Testing report?
I think I would definitely consider treatment because as Dr. Chadha mentioned in that slide, which was so beautifully said that, a previous fracture begets the second fracture. So when he showed this chart where a person who has a wrist fracture, the chances of him getting a second wrist fracture was 3.3 and getting a vertebral fracture was 1.7. So basically the presence of a fracture itself indicates that the bones are weak and it definitely merits considering starting the patients on osteoporosis medications to prevent future fractures. So I would definitely consider treatment in this patient.
Thank you, ma'am. So what is the importance of family history in patients of osteoporosis? Like we usually ask for diabetes and thyroid, but in relation to osteoporosis.
Family history has a very important role in osteoporosis as well, because as we heard all the speakers talk about the peak bone mass, where genetic factors are very important for peak bone mass. So if you have a family history of osteoporosis in a parent, or if the daughter has it in the mother or the sisters, it definitely reflects on a poor peak bone mass, which could have a genetic relation. Even there are a lot of genetic loci like the vitamin D receptor polymorphisms, because vitamin D is very important for calcium absorption in the gut. So even these polymorphisms are known to have effect on osteoporosis. So family history definitely plays an important role. And we should ask for family history when we are talking about the risk factors of osteoporosis. And that's one of the reasons family history is also considered when we are calculating the fract score. So definitely family history holds a merit in the risk factor for osteoporosis.
Thank you, ma'am. So from the second case, we can have two take-home messages. Like most common cause of high PTH in clinical practice is vitamin D deficiency. So without, first we should correct vitamin D deficiency. Then we should think about the other etiologies of high PTH. Again, OADs like pioglitazone should preferably be avoided in postmenopausal women because it can worsen the pre-existing weak bones. So after this two cases and question and answer session and take-home messages, I would like to conclude and would like to tell that this patient was also managed in the same way, like calcium, vitamin D was given, exercise was advised, once stable. She was also prescribed 5 milligrams zoledronic acid and was asked to follow up with the scan, Bmd Testing scan after a year. So I would like to thank by concluding and hand over the session to the organizers.
Thank you very much, Dr. Pankaj, for conducting a fantastic session. So just to summarize, there were two cases discussed. The first was fracture spine. Some very important points came out of that. One is not every fracture spine needs surgery. Most of them can be treated conservatively. One has to rule out pathological fracture, and surgery may be needed only if there is instability or there is a neural compression, or one has already given adequate conservative treatment and patient is still uncomfortable. But otherwise, most of them can be treated conservatively. Dr. Kanchan brought out some very important things about diabetic neuropathy and imbalance, using appropriate footwear, and essentially prevention of falls. Another important thing she said was fracture, low trauma fracture is an indication for surgery irrespective of BMD. Importance of over-treatment of hypothyroidism cannot be overemphasized. Many of them do go into osteoporosis. And this was the first case. Dr. Dwivedi, would you like to summarize the second case? Dr. Dwivedi?
Yes, sir.
Yeah,
Sir,
would you like
sir,
to summarize the second case?
No, sir, I think in front of you, I should not just be you. Please go ahead.
Okay. The second case was case of fracture neck femur, which was operated, and cholesis fracture. For the benefit of medical people, these days we hardly ever call a cholesis fracture a cholesis fracture. It's essentially a lower end radius fracture because it's too complex an entity. Some or many of them can be treated conservatively, but incidence of deformity is very high, and that is why some of them, especially intra-articular ones, are operated. High PTH was, importance of high PTH was brought out. Most of the times it is vitamin D deficiency which would lead to high PTH or secondary hyperparathyroidism. And the last two very important points Dr. Kanchan said, where fracture lower end radius is often a point of initiation or starting point for the therapy, osteoporotic therapy. And secondly, family history is very, very important as far as assessment of osteoporosis is concerned. Thank you very much all for a very lively panel discussion. Thank you.
Before you all conclude, could I have all of you all put on your cameras because I need a photograph to send to IOF.
Thank you, everyone.
Thank you.
If I knew, I would have worn a tie or at least a shirt here, not surgical attire.
It shows how dedicated our orthopedic colleagues are here. रात को 10:30 बजे they are ready to operate here. Mohan, have you reached home or still on the auto? Vaishali, please, if you are around. Okay, good. At least I've got a couple of good faces smiling. Thank you.
Would like to thank the Endocrine Society, Maharashtra Endocrine Society, for giving me this opportunity with this interactive CME, and it was really wonderful to listen to all the speakers on this world osteoporosis. Thank you so much.
Yeah, I think I extend my gratitudes to IMA Mira Bhayender, Team Digi Shield, Dr. Reddy's, and most importantly, our all orthopedic colleagues. I think it is a new beginning that probably has happened, an event where there was equal participation from endocrinologists and orthopedicians. Orthopedicians think that endocrinologists know only theory, and endocrinologists think that orthopedicians, I would not complete the statement anymore. But I must tell you that there is a lot to learn from each one of us. I continue to discuss with Dr. Aditya and learn new things, new inputs from him in managing each and every case. And I think with every interaction, we just become more and more wiser. We need to respect each other. We need to grow with each other because we are fighting a pandemic of osteoporosis for which we all need to gear up pull up our resources, pull up our sleeves. There is a lot to do, including something from like a fracture liaison service. And I think this could be very well be a beginning of forming a group which can go ahead and do that. I would like to thank Dr. Milind Patwardhan sir for taking out his precious time, our president. Team IMA Mira Bhayender, Dr. Amol Jadhav, Dr. Jagruti Ghosh, Dr. Navneet Desai madam, Dr. Dwivedi sir, who all stood like a rock with me. All the Maha Endocrine Society gang, our Vice President, Dr. Mohan Magdum, my colleagues, Dr. Chandni and Dr. Aasim, my senior colleague, Dr. Kanchan, and Dr. Pankaj, all our orthopedician colleagues, Dr. Agashe sir, Dr. Bijlani, Dr. Tikku, Dr. Aditya, our MMC observer, Dr. Jairaj Nair, anyone whom I have missed. I think wish you all a very, very happy Diwali and thank you for joining. Should we call it a day?
Thank you.
Thank you very much. Bye-bye. Well in time.
Bye. Bye.
Recording stop.